Good morning, afternoon, evening to all our speakers and delegates. I'm Robie Kamanyire, and as co-chair of the Chemical Events Working Group of the Global Health Security Initiative, it gives me great pleasure to welcome you to this final day of our symposium on enhancing public health management of chemical incidents through collaboration with poison centres. If you need more information on the Chemical Event Working Group or GHSI, please see the video of the first day of the seminar, which is available on the infopoison.ca website. I'll quickly refresh the objectives for the symposium. Firstly, to highlight the value of collaboration between poison centres and public health entities for the preparation and response to chemical incidents. To discuss the benefits and challenges identified by poison centres and public health teams during the response to a chemical incident. And finally, to share best practice or lessons and propose strategies to optimise collaboration between poison centres and public health agencies during chemical incidents. We've had 8 great case studies presented on the previous 2 sessions, and for this final session, the speakers have kindly joined us to reflect on their experiences and discuss what is needed by poison centres and public health entities to improve future responses, through identifying best practice and any residual gaps that remain to be addressed. There will be opportunities to ask questions following the case study reviews. But before the case study discussions, we have 2 presentations. Firstly, Lesley Onyon, head of the WHO Chemical Safety and Health team, will provide a keynote presentation on the role of poison centres and public health. And then Mark Hailwood from the OECD Working Party on Chemical Accidents will discuss chemical accident prevention, preparedness, and response. In terms of the logistics for the day, we remain in the capable hands of the team from the Canadian National Coordinating Centre for Environmental Health, who alongside the Chemical Emergency Management and Toxicovigilance Division of Health Canada are kindly hosting and coordinating this event. As with the previous symposium sessions, we will be using Slido for questions, and a reminder to please like or vote for a question. Those that receive the most thumbs up will be answered by the presenters first. Again, a reminder to please complete the symposium evaluation survey. A link will be shared during and after the symposium. At this point, it's time to start the seminar proper. So I am therefore very pleased that we have Lesley Onyon, head of the Chemical Safety and Health Unit at WHO headquarters in Geneva, to provide a keynote address. Lesley has extensive experience in this area, having worked nationally and globally on chemicals management, as well as on strengthening poison centres. Lesley, you're welcome.
Thank you very much, Robbie. It's a great pleasure to be here. So thank you very much for the invitation. In the next 15 minutes, I'll just run through a little bit about the current standing of poison centres and the public health. This is very much from a perspective of WHO, so I'll sort of set that out immediately. And I know that the speaker after me is going to be talking in more detail about the specific chemical accident context. So hopefully between the 2 of us, we'll have got this just about right. First of all, what is a poison centre? So I think you'll have heard from the case studies and from your own from your own background that a poison centre can be many different types of centre. There's no one size fits all. And we see on this slide that it can be an information unit, it can be in a clinical unit, it can be laboratory-based unit, and other units based at universities and so on. At the core activities of a poison centre are often characterised as providing advice over the telephone to assist the diagnosis, clinical assessment and management of poisoning. And in order to do that function, they need to access information about the risks associated with chemicals, products, and natural toxins, the available management protocols. And in the course of doing this, they compile this information in various ways that maybe have databases or other forms of records they have access to online databases. I've put toxicovigilance and surveillance as a core activity also because it naturally falls out of the fact that they're receiving signals, they're providing advice, and they've got information, and they they will be recording the advice that they give. However, I think that it's probably not as sort of commonly recognised, this toxicovigilance surveillance function, that poison centres do automatically, but don't necessarily formally sort of use these signals and vigilance information. But that's what we think would be the core activities of poison centres, and the advice can be provided, 24/7 and so on. Other activities associated with it are surrounding these core activities: poisons prevention, health promotion type of activities, helping with supply of antidotes, chemical incident response, teaching and training, adverse drug reaction reporting, occupational toxicology, ecological toxicology, and veterinary toxicology, and there could be others. So there's a very wide range of activities that not all poison centres do, but we recognise these three core, providing advice, compiling information, and toxicovigilance is really the core activities. The sad fact is that less than half the countries in the world has a poison centre, and here you can see the location of poison centres worldwide. And whilst you see that many parts of the world have got quite a lot of poison centres, notably North America, Europe, you see very large tracts of the world don't have any poison centres. So it is a key concern from a public health perspective. Why does every country need a poison centre? Well, they deal with matters of public health concern. We know that the burden of disease from unintentional poisoning is very large and totally preventable. We know that human exposure to chemicals is increasing. We know that poison centres are often the only place in a country that can provide that very specialist advice needed to manage poisons, detect new cases of poisoning, and also advise in treatment, and that they have a critical place in the implementation of global and regional policies relating to sound management of chemicals. An often overlooked point is that they do add meaningful value to healthcare systems, reducing costs and saving lives. The slide here highlights a very useful fact sheet that was developed by the European region of WHO, and it's available online, and it covers these key details of why every country does need a poison centre. We know that what is known about the burden of poisoning is only the tip of the iceberg, and a lot more information is needed, not only on acute poisonings, but also on diseases caused by chronic exposures and also other diseases in the general population that often go undetected. We also know that the core capacities to implement global agreements, such as the international health regulations, have consistently shown that the capacities for chemicals management in countries continue to be the most challenging and are among the lowest all 13 capacities. There's a wide range again from different regions, ranging from only a capacity of 36% in the African region as being the lowest there. So again, this is consistently the lowest reporting of all of the core capacities of the IHR implementation. When we look at distribution of those poison centres wide, whilst we can count the 347 poison centres that we are aware of and the countries in which they're based, we see that there is very disproportionate distribution of those. And we see in this bubble diagram that Europe is the most well served, with 70 poison centres in 35 countries. In the Americas, there's many more poison centres, but fewer countries. But unfortunately, as we showed on that picture of the world earlier, the African region and in Southeast Asia are very poorly served, considering their population densities. Why does this disparity matter? Because we know that there is still a very fast growth in chemicals production, and this is projected to rise most dramatically in non-OECD countries, and they are the ones which don't have generally the poison centre as networks in place. So here we see that the OECD projects the growth in chemicals production to be almost fourfold by 2050. So with those challenges in mind, it's very important that we continue to raise the profile of poison centres in relevant policy contexts. And we really recognise three key policy contexts here. The public health priority context, where we have a particular focus on preventing deaths from suicide, access to essential medicines, maternal and child health initiatives, and other population-wide initiatives. The emergency preparedness and response of the international health regulations. But also we work very much hand in hand with different international chemicals management policy contexts. And here we have the Basel, Rotterdam and Stockholm Conventions, the Minamata Convention on Mercury, and also the newest agreement that we have, which is the Global Framework on Chemicals, which was adopted in 2023. And poison centres are recognised in all of these different initiatives. In WHO, we've been working to put poison centres on the map, but more specifically in the WHO Chemicals Roadmap. And this is a roadmap for setting out the actions where the health sector has an important or leading role to play in chemicals management. Too often we hear from our health ministries that, oh, because this is chemicals, this is handled by another ministry. And so there's still quite a lot to do to set out very clearly what are the key roles that the health ministries need to do as part of enabling chemicals to be managed soundly. And this roadmap was adopted by the Health Assembly in 2017, and we're currently updating it to reflect the development since then. But poison centre activities are integral to the roadmap, including enhancing toxicovigilance, identifying priority chemicals for national assessment and management, identifying and describing national indicators of progress for reducing the chemicals burden of disease, contributing to strengthening various networks, including the WHO Risk Assessment Network and the Poison Centre Network that WHO has, as well as establishing and strengthening IHR core capacities. The bottom line is that we want to ensure that all countries have at least access to one poison centre, and we're very far from that situation at the moment. I mentioned the Global Chemicals Framework is a new international agreement that was adopted in 2023. Under this framework, we're very pleased that there is a specific target for tracking the success of the framework, which relates to poison centres. And this target is that by 2030, all countries should have access to poison centres equipped with essential capabilities to prevent and respond to poisonings, as well as access to training in chemical risk prevention and clinical toxicology. So we're currently working with UNEP and other international organizations to put in place a tracking system for how we might monitor this. And whereas I mentioned that WHO has a directory of poison centres, I also mentioned that these poison centres are of vastly different capacities. So we really perhaps need to be considering really how to hone that down so that we are measuring real progress in strengthening capacity and not just the numbers of poison centres that exist. There are a number of initiatives in WHO regions. In the Americas, they very much focus on strengthening regional networks, and they have a virtual platform for training and information sharing. They are also keen on strengthening the role of poison centres in public health emergencies. In Europe, as I mentioned, there is a new partnership on poison centres, which has been launched at the Health and Environment Ministers meeting. In Africa, there is a regional network of poison centres to basically build that capacity and to help to establish poison centres in those countries which don't have them. In Southeast Asia, a focus is on improved procurement of antidotes, also networking existing centres. And in the Eastern Mediterranean, again, regional networks are very important, as is strengthening the collaboration with professional bodies such as Menotox. A number of global issues have been identified as priorities for collective action, including the issue of toxicovigilance. As I said, it's really under recognized that this is a core role of poison centres, improving data collection, improving antidote supply, improving the ZEP poison center databases, preventing pesticide-related suicides, capacity building and training, and strengthening linkages with emergency response, particularly in relation to the poor capacity as reported by countries under the international health regulations. We have a number of key sources of information: the Manual for the Public Health Management of Chemical Incidents, which is being updated at the moment, the guidelines for establishing a poison centre, as well as courses being developed under the WHO Academy for first responders, and also for the policy context of poison centres and chemicals management. So this is the guidelines. I think in the interest of time, I won't go through these in detail, but they are available on our website. This identifies some of the key areas where poison centres have a role to play in the public health management of chemical incidents. And I'll finish with a few observations about the needs to strengthen poison centres and public health, several of which I've mentioned already. But obviously, it's very important for their networking, both globally and regionally, not only for capacity building, but for establishing those toxicovigilance mechanisms. In terms of national governments and ministries, there needs to be a better appreciation and dialogue between those ministries, as well as an appreciation of the role that poison centres play. I think that sometimes I wonder with the international health regulations that maybe they don't have the same picture that they would do if they went to sort of assess it amongst the ministries of environment. So I think that that sometimes there's not a good knowledge amongst different ministries about what the different capacities are within each sector. So again, a need to have a better understanding about the role of poison centres still. Enhancing the role for professional bodies. I've mentioned Menotox already, but also recognise the APAMT, EAPCCT, of course, the American Association, and a growing one in Africa, Afritox. We need to really build upon means of implementation with an emphasis on twinning arrangements and bilateral support, as well as multilateral support. The private sector and philanthropic support has been something that poison centres have relied on heavily in the past. But again, this is not necessarily sustainable always for them. And we have a number of examples where very well-established poison centres have been struggling in recent years. Again, I think that ties back to the need for a better appreciation and of the role of poison centres, and perhaps more promotion by the poison centres themselves about what they can do to help these different initiatives. So I've already touched on there what an observation of ours is. What we're working very hard in terms of strengthening the appreciation of ministries of health. We'd like to see stronger linkages between the ministries of health and the poison centres, including recognising their role not only in national chemicals regulatory management, but also health system strengthening. And then some of the key topics which come up: toxicovigilance, capacity building for first responders, antidote availability, strengthening the capacities of the IHR, and so on. So a very quick run through there of poison centres context from a global perspective. I'm happy to join the meeting for the rest of the duration and answer questions as they come up. Thank you very much, Robbie.
Thank you, Lesley. Really excellent presentation to kick off this symposium today. You can have a moment to catch your breath as there'll be a presentation from Mark to come. We already have a few questions in the Slido, so I can encourage others to add their questions, but please don't forget to promote your question by using the thumbs up, as the question with the highest number of thumbs up will be answered and addressed first. So it gives me great pleasure to welcome Mark Hailwood, who's a scientist from the LUBW State Institute for Environment in Baden-Württemberg, Germany. And Mark has worked for over 30 years on chemical safety and is today presenting as Vice Chair of the OECD Working Party on Chemical Accidents. Many thanks, Mark.
Good morning, good afternoon, good evening, wherever you are in the world. It's a great honor to be able to speak to you and to help build a network between two very different areas of the scientific and technical world, who have a very interesting point. No one actually wants to talk about the interface between the chemical accidents that take place and the health responses, because no one actually wants to have chemical accidents. If you are not aware of the OECD or the OECD Working Party on Chemical Accidents, the Chemical Accidents Programme of the OECD came about following the Bhopal disaster in December 1984, 40 years ago. There were various meetings in 1985, and in 1986, a high-level ministerial decision was taken that the OECD should establish work in this field, and that we should strive that something such as Bhopal should never happen again. And that is the foundation of what we do. We have, as a main piece of work, something called the Guiding Principles for Chemical Accident Prevention, Preparedness and Response. This is now in the 3rd edition. About every 10 years we have managed to update it, and this document provides guidance to support stakeholders in taking appropriate actions to prevent, to prepare for, and to respond to chemical accidents. You may ask, well, what do we mean by chemical accidents? Any accidental release of chemicals, usually industrial chemicals, at fixed installations, although we do also consider pipelines. And we have heard in the series of webinars in about 3 incidents in the last couple of weeks: the release of ammonia from a refrigeration unit in the Philippines, a chlorine release from a gas bottle in Oman, and a major chemical accident in Chile, which was talked about last week. These are the type of events that we are interested in preventing. We realize that not everything can be prevented, so appropriate preparation measures must be taken, and in the end, should such an event occur, response to the accident must be taken. This is technical guidance and underlies the application of the OECD decision recommendation concerning chemical accident prevention, preparedness and response, which was updated and consolidated in 2023. That is the regulation of the OECD setting out the intentions, the binding commitments of the member countries or non-member countries who decide to adhere to these requirements, and also recommendations of what is good practice in this field. So I'd like to take you through the OECD guiding principles and indicate where there are opportunities for public health authorities and poison centers to be involved, because I think this is the key element. We have prevention, preparedness, response, and following an accident, there is the follow-up, the cleanup, accident reporting, and investigation. How do the OECD guiding principles address this? The prevention is an engineering exercise and usually covered by the labor inspectors and the environmental inspectors enforcing their regulation, covers the design, the construction, the operation, maintenance and repair, management, goods safety management, land use planning, where are facilities sited, not necessarily directly next to a hospital, inspection and enforcement activities. This is prevention, and if everything works here, there will be no accidents. Next stage, being prepared for releases of dangerous substances, which may lead to either toxic effects, ecotoxic effects, or fires or explosions. So we have detection systems, alarm systems, mitigation systems, which may be foam being spread out onto a bund around an oil tank to prevent dispersion and evaporation, emergency plans, internal fire brigades, external fire brigades, very important emergency drills. People need to know what they need to do in the event of an emergency. And also, what is more and more important is designing information for the public, preparing to be able to inform the public in the event of emergency what they should do. Come to response. Response is the stage something has gone wrong. Something has happened that no one wanted. And at this stage, mitigation systems must be activated, which means you need to have taken the preparedness step. If you have not done your preparedness, there will be no mitigation systems to be activated. Emergency responders must respond. Emergency responders can only respond, though, if they know what they should be responding to. The emergency planning has to have taken place. Alarms and information to the public. Again, there is no point in alarming and providing information to the public unless you have informed them beforehand what they need to do and also decided what information you are going to provide in what form. We have in Europe, there are many hazardous sites very close to international borders. How do we make sure that information crosses the border? Because the toxic chlorine cloud does not know where the border is, and within 5 minutes, it could be a kilometer away and already on the other side of an international border. Things like this are important to prepare for, to allow things like this to happen. Following the response, when the fire has gone and the blue light organizations, the emergency responders have all gone home, what is left to do? There are roles for public health services, epidemiological studies into how people have been affected, soil and water remediation, and also roles for the enforcement authorities looking at what went wrong and why it went wrong and what has to change to make sure there is not a repeat. So this is a view through these stages of the OECD guiding principles. Very brief, and it's a fairly thick book, but these are the stages that we've covered. So in an overview, that's what it looks like. So what about the opportunities for public health authorities and poison centres? Well, the health authorities are not really involved at the prevention stage. You don't operate the plant, the industrial sites. You're not involved in maintenance and repair, land use planning, inspection. This is a phase which is perhaps not so important to be involved in or aware of. However, preparedness. If you are going to have effective response, preparedness is vital. And the civil protection bodies and the fire services need to know how to respond safely. So toxicology and acute treatment advice should be developed for the emergency plans. They should know what sort of chemicals they're likely to face and how they need to respond to them. Some chemicals require very, very explicit treatment forms, and some of them require measures to be held in readiness, either with first responders or in the medical centres and hospitals that respond and take injured persons for treatment. Now, it is not sufficient just to have information. Training should be provided. Medical staff and paramedical staff, the emergency responders, need to be trained. They need to understand how the treatment should be administered. In the treatment, for example, for hydrogen fluoride poisoning, requires that the gel is rubbed into the wound. Now, this is very difficult to explain to people who have never been through that training and never understood. Often people are very cautious about putting things into the wound, but the important thing about the hydrogen fluoride treatment is that it gets to the seat of that wound as fast as possible, and it needs to be, so this treatment needs to be applied in a very specific manner. In treatments with oxygen, do your medical responders have sufficient oxygen to be able to respond to those sort of events? And this can only be verified through participation in drills. Now, I have been involved in major accident drills a number of times over the years. I've been involved in over 30 years of this sort of work. And one of the problems that we have often discovered is the ambulance services and the first responders, they are involved. They participate, they come. The local Red Cross teams, they'll come. Getting the hospitals involved actively to realize how will they deal with the requirement that they need to free up a certain number of beds as soon as possible. How will they respond when they have to carry out triage of the patients that they are receiving and work out what to do? How will they receive them? Will they be able to do simple things like provide them with drinking water, coffee and tea for those people who have to wait? They're not seriously injured, but they may need simple treatments. Getting that managed and understanding what can go wrong is an important part of carrying out drills. And it's important that we involve health authorities and poison centres and all of the medical staff within the whole of this framework in the preparedness if we want to have effective response. In the response phase, there is very little that can be done which is new. If you have not done your preparedness work, you are not aware, you will not be able to respond as quickly as perhaps required. It is important to not forget that if you have a wind speed of 3 meters per second, which is a quite normal everyday wind speed, your toxic gas cloud will be 1 kilometer away within 5 to 6 minutes. If you need to spend time researching your response, you will have already missed the opportunities to be able to provide effective information to first responders. You may end up having to treat more people or manage a higher number of mildly affected people than if adequate information was already provided and already with the civil protection authorities and already with the fire departments. You can provide acute treatment advice in an emergency and you can support the response. But this, I think, is perhaps not the best use of the time. Invaluable scientific information is probably most effective when it's in the preparedness phase. Then you can ask questions, you can check and make sure you have up-to-date information. You've got the best available response and the best trained staff that you can do. And afterwards, there is a role for public health authorities afterwards, and possibly also for poison centres, updating information, learning the lessons from an event, but also implementing epidemiological studies, understanding how were people affected. Were people of a particular age group affected? Were people warned sufficiently that not affected? This needs to support decision-making regarding the exposed populations. Can people return? Can people eat the food that they've grown in their garden? Can farmers harvest the crops that they've planted in their fields? Does soil and water need to be remediated? This requires information also from poison centres and public health authorities to enable effective responses after the fires have been put out and the toxic cloud has dispersed. There is a lot of decision making left to do. The OECD guiding principles have been worked out together with many different organizations. UNEP, United Nations Environment Programme, has been involved, and in the past the WHO has also been involved in. We have an annual meeting in the autumn. It would be nice to see the WHO return to that meeting and allow us to develop and share information that we do have and look at things that could be done better. What can we learn from each other? And this is also an opportunity for this organization, for the JHSI, to also perhaps build contacts with the OECD Working Party on Chemical Accidents. It's a very open group. We are open to discussing with anyone who wishes to help in the prevention, preparedness, and response to chemical accidents. And also, if you are an OECD member state, member country, and you don't come, or you don't have a delegation that comes to the Working Party meetings, you can register your interest and make sure you come to the next one. They are hybrid meetings. The meeting takes place in Paris, but there is also an opportunity for online, and we share a lot of information. And the saddest thing that we keep seeing is repeats of accidents which were reported 2 or 3 years ago in one country will be reported several years later in another country. And it's so important that we learn how to do things better. So the opportunities which I see, and I've shared this presentation with the Bureau of the Working Party on Chemical Accidents, and they support these, is in preparedness, supporting the development of emergency response plans, ensuring that all the necessary information is up to date and can be made available to those who require it, and participating in emergency response drills. Medical services such as hospitals likely to receive injured need to be involved as well. Some chemicals require specific treatment. Cooperation with first responders to ensure patients are decontaminated, or how to carry out decontamination, that needs to be planned and exercised. We had an incident several years ago where a patient who had been exposed to a substance which spontaneously combusted. They had enormous problems evacuating this patient with a helicopter because sparks kept appearing in the clothing, because dust particles had seated themselves in the clothes of the patient. Things like this must be considered. Information distribution networks to general practitioners and pediatricians in an emergency should be prepared and thought about in advance. I say pediatricians, they are known to be some of the medical profession who are most widely trusted. The general practitioners and the pediatricians are the people go to get information in emergency. It's very often, certainly in Europe, not their local politicians. Support the local response if required. And this may be involving advising local government officials on the acute effects of airborne dispersion, but information needs to be available. It needs to be prepared. And it's likely to lead on to the follow-up and the cleanup phase of the incident. Oops, that went too fast. Follow-up and cleanup. Think about health studies and epidemiological studies that may need to be carried out. If a large population is exposed to a toxic gas cloud or a rather unknown chemical, it may be uncertain as to what the short-term, medium-term, or long-term effects are. This requires some planning. You need to provide advice on consumption of fruit, vegetables, and agricultural products. Advice may be required from local physicians how to advise concerned patients for a period of time after the event. It's not the first 24, 48 hours. This may go on for weeks, months. Some may come back and say, oh, they have a lump, or they feel unwell, and attribute this to being potentially exposed to a hazardous chemical. it's important to be able to make advice and information available for some time after. And something which is perhaps outside of the scope of the poison centres, but in the follow-up, mental health concerns of employees, first responders, medical staff and their families and friends, as well as the general community, may also be something that needs to be considered, particularly by the public health authorities. Being exposed to a difficult situation is not an easy thing for a community to deal with. Information is something that needs sharing. Public authorities have a lot of information. The operators of hazardous facilities have a lot of information on the health hazards of their substances. Civil protection authorities have information which they use. There are also 24/7 support systems of the chemical industry. This needs to be used and built into the systems of the poison centres and the public health authorities. If you use the time before an accident to make sure you can find out what information is available and how to obtain it and how to regularly update and exchange information. There are also international standards in classification and labelling of hazardous substances and providing safety data sheets. Physicians need to be aware of this. We shouldn't create parallel worlds and parallel systems. Within many of the industrialized countries, there's a considerable experience gathered over a long period of time. Therefore, the cooperation between countries, between international organizations, and between all the stakeholders is very, very important. And it's a great pleasure to have been able to present this to you. Thank you very much.
Thank you very much, Mark. A really comprehensive presentation around chemical safety arrangements. I'm very happy to open it up to questions. I can see we have quite a few questions. Acknowledgement that this varies widely, but a question about the funding for poison centres, and then following on from that, the strategies for increasing the funding as the individual would like to get the centre more involved in the planning and operational activities, preparedness, I presume, for incidents, but acknowledging that that would require more funding.
So I think that it is a very diverse range of funding, and I think that poison centres have had to be very creative and in their getting funding sources, because it's it's likely that they would get some funding from the health service, providing sort of support for emergency type work in poisonings, but this is not necessarily always given, but they would be expected to get some funding from that source, but that's not going to cover all of the services that they may wish to be involved in. So then they can go for funding from the private sector, from pharmaceutical companies, from pesticide manufacturers, from different charitable funds, from different international organizations. Sometimes, so like fee for service is also used by some poison centers, but there isn't a sort of a magic formula here. And I think, as I mentioned in my presentation, even very well-established poison centres, and I don't want to name names, but I think we're probably all aware of some of these if we think about it, struggle for funding. So yeah, this is something that's if you look at the WHO guidelines, there is details of the different funding sources which have been successful in the past, but it's not likely to come from one source. It's going to be sort of cobbled together from a number of sources, and that creates some vulnerability as well. I mean, there's strength in having funding from different sources, but also, if you have to be applying for grants every year and so on, and they're not always guaranteed, it's quite a lot of vulnerability there too. I think that's probably always been the case, and why we also think that the ministries of health need to be a lot more linked in with the poison centres, so that they are seen as a vital thing and not just a add-on extra, because we all know cases of poison centres being provided by a sort of a voluntary capacity by some, very committed emergency physician on his mobile phone out of hours, and that's not really any way to sort of to strengthen the whole system. And Mark's presentation was great in pointing out all of these things that poison centres can do, and we fully agree with that. But where they find the funding to do that is really the challenge.
Great, thank you, Lesley. I think we'll move on to the next question, which again is a bit challenging to address, but how often are poison centres consulted or accounted for during emergency plans or drills in preparedness? I think more the second part of this question is an interesting one. According to WHO or OECD guidelines, how can the poison centres be a more prominent player during preparedness? And I'll slightly use the chair's prerogative here and sort of say, do we have it written into the guidelines that certainly for OECD and WHO that they should participate? Acknowledging, Lesley, your last comment about putting additional pressures onto poison centres. Yeah.
I don't think it is already. I mean, it's something that's mentioned, and I know that even talking to our own IHR people, and when they do have simulation exercises, it's clearly that they don't always think of poison centres. They don't always know that a poison centre exists or it's interested. So I have to be honest to say I don't think it happens that often, and I think that also the other sort of complicating issue with this is that sometimes chemical accidents can be under the sort of purview of sort of military and security sort of organizations, and they probably, that is an extra barrier, I think, also for using more military hospital type support rather than the public health system. So it varies tremendously, and it's a good point, and finding ways to sort of really to institutionalize that it's a challenge I think we should all be working on.
Thank you, Lesley. Mark, do you want to comment?
No, I would agree entirely with what Lesley said. It's a case, if you don't use them and involve them, then they will never have the role. It's a chicken and egg situation. In the OECD recommends involving them, but you can't force people to do things, and if people are not used to using them, then they have to overcome these barriers, and it will vary from country to country.
That's fine, thank you. And maybe this is one of the gaps or discussion points following on from this seminar, is how they can work more closely, the public health entities who are more likely to be involved with some of the planning and preparedness activities as well. So really useful point to flag. I think we've got another question from Awal in Nigeria. I think you've touched on this already. Can a poison centre be established as a private entity, not under government ministry or agency, and be supported by WHO?
Yeah, I think there are a number of examples of poison centres set up as private entities. I think that that can add to the complications. We've already talked about we need to strengthen linkages. I think that if it's a private entity, it makes it even more of a challenge, especially when you're talking about national security, response to chemical incidents and these things, which are really the responsibility of the government. They may not feel sort of comfortable sort of making those linkages with the private entity, but there are a lot of private sector poison centres, and that we list them in our directory, and we engage with those poison centres as much as any others, but I think it can be a blessing to have a private source of funding, but I think it also provides some challenges for those strengthening the linkages with the public health system and the ministries of health. Often they don't know they exist.
Thank you, Lesley. Question for Mark. Why are the same incidents happening year after year in different countries? Is there not a sharing of lessons learned undertaken across the network to prevent a repeat of the same incident in a different country?
It's not a lack of information. We have databases. There is a journal from the Institution of Chemical Engineers called the Loss Prevention Bulletin that only writes about accidents. There are conferences. The expertise, they exchange a lot of information. The problem is learning. The problem is taking someone else's accident, identifying your situation within their accident and applying it to yourself. And people are just not very good at that. And the OECD has recognized that. This is actually one of our key projects for this work program starting in January 2025. We have a 4-year work program. One of the key projects for this year is how to improve the learning in the learning from accidents. And there will be workshops and webinars hopefully in the second quarter. There'll be a webinar and anyone is invited to attend online. And it's there to, how can we improve the learning? How can we get the messages out of the box using lots of different tools? I could spend hours talking about it because this is one of my passions. You're right. Whoever asked the question, you're right. People are not doing it. It's not a lack of information.
Okay, thank you, Mark. So possibly another point there in terms of recognizing the importance of learning from past incidents to inform and prevent future ones. So thank you as well for the individuals who asked the question. Another question for you, Lesley. Thank you for a wonderful presentation. What kind of support can WHO provide, especially to low and middle income countries, to establish and sustain poison centres, and how can we access these supports? And that's from a question.
Well, I wish we could do more. We also are struggling for resources in this area, and I think that there's no secret about that. I think that what we've been doing more in recent years is focusing on the building sort of networks and trying to sort of share resources sort of regionally, because when you talk about establishing a poison centre, it's not something you just go out and rent a building and establish a poison centre. You've got to sort of build it up, the service incrementally, and there's a lot you can do with networking and sharing this capacity building sort of activities and training. So that's something that we're also wanting to get sort of embedded into different regional commitments and agreements with ministers. And so that also helps to sort of more strengthen the understanding of the importance of the role of poison centres. So we obviously, if we are aware of any sources of funding that's relevant, we gladly share that. We also want to encourage through the head of WHO country offices to be more aware and to advocate with ministries of health. So we're involved in those sort of activities. Unfortunately, we don't have a sort of pool of hard cash to supply ourselves, but there are a lot of things we can do with networking, capacity building, sharing experience, and so on, as well as advocating in the policy context.
Okay, thank you, Lesley. I think we're running short of time, but we'll take another couple of questions. Do you think poison centres have a role in monitoring chemical incidents, eventually in cooperation with other organisations and authorities?
Yeah, I think that's something I think is very important, and I think it builds on what Mark was saying about learning for the future. You have to, and there are organisations which compile lists of accidents, but it's not necessarily, there may be a number of sources, and I know that there's more informal ways of monitoring accidents as well, whether it be by monitoring the press clippings and so on. So I think there is a need to share that, because it will just raise awareness and also be a resource for countries to learn from those accidents and try to prevent them happening in the future.
Fantastic, thank you. And then there's a question for Mark again. Thank you for an exciting presentation. please, is a petroleum tanker accident which resulted in fires and mortality regarded as a chemical accident?
Yes and no. It's a chemical accident,
Yes.
but it's not. If it's at sea, it's an accident that is of interest to the IMO, the International Maritime Organization. They have their procedures for dealing with these types of incidents. If it happens to be a tanker which is in a port area, this will definitely interest the OECD Working Party on Chemical Accidents. These are also accidents, and these are the types of accidents which are becoming more and more interesting as more goods are shipped around the world, and in particular as people are starting to think about moving large quantities of hydrogen and ammonia, usually from less economically developed countries to highly industrialized countries. And this means that some countries are going to end up with challenges for dealing with technologies and substances that they have not encountered before. And I think there are definitely some strategies and plans to be made before things like that happen, but they could happen very quickly. But in this case, the tanker, if it's at sea, it's an IMO issue. If it was in a port, we would consider it as a chemical accident within a port area, and it would definitely be of interest, although it's probably mainly maritime in its origin.
I think the question was sort of referring to the fuel road tankers.
Road tankers.
Yeah.
I thought it was a shipping tanker. If it was a road tanker, those will be road transport tankers. They will be under the Road Transportation Authority. In Europe, we have something called the RDR, which governs transportation. It would be wonderful if many countries would adopt similar transportation regulations. We wouldn't consider those to be chemical accidents within our remit. However, the Working Party on Chemical Accidents has raised concerns, and we're not responsible for them, but we do have a lot of concern because this is one of the increasing types of accidents that we've seen, particularly in Africa and in Southern Asia. And the measures to prevent them are relatively simple. And the biggest problem are not the accidents, but the people going to gather spilt fuel afterwards. Once spilt fuel, kerosene, petroleum has been released. And I think this is perhaps an opportunity for people with chemical accident knowledge to work with health specialists who are good at getting information into the public field of how can we get this to work, because 20 to 100 people being killed gathering spilt fuel is not acceptable. So sorry about that. I thought the tanker was at sea.
No, it's fine. You covered all the options now, so that's really helpful. And then we'll take one final one, which is from Helena, which is, where can you find information on when the consumption of fruit and vegetables is safe after a chemical event?
This is something your local public health authorities should be providing information on. This is
Good example.
this is their job. If there has been a chemical accident, there should be information provided to the public about that there has been something, but your public health authorities, local authorities, town halls, or however it's been organized. However, if it's not been organized, and this is what I meant about the preparedness, if it's not been organized, then I'm afraid there will be no information, and people will have to make their own.
And there would be maximum residue limits and so on that would be set out in codex and whatever for fruit and vegetables. It would require local testing, and but as Mark said, a lot of the role of the public health authorities would be on issuing advisories to people about washing the fruit and vegetables and so on, and other measures that need to be taken.
So it will be part of the multi-agency response, bringing in the food specialists to advise as well, as Lesley has said, around the wash and peel. And then, as he said, the limits of residual contamination within the fruit and vegetables will be available as well from a variety of sources.
It requires preparedness. If
Yeah.
it's not going to happen on its own.
Yeah. Again, my thanks to Lesley and Mark for fantastic presentations, really helpful introduction to the day. We will be capturing all the unanswered questions within the Slido, and we'll be looking to get those addressed and answered under a theme process as we go through and go forwards on the day. If we then move over to our first case study, again, please do continue to add your questions to Slido as the case studies are being presented, and they will then be addressed. So the first case study was on an ammonia mass casualty incident. It gives me great pleasure to introduce Dr. Irma Makalinao, Professor and Coordinator of CBR and Health Initiatives at the University of the Philippines, Manila, and Dr. April Llaneta, Chair of the Department of Emergency Medicine at the University of Philippines, to represent your case study and the lessons identified from that and suggestions around improving best practice as well. Thank you.
Good morning, good afternoon, and good evening. I know that here in the Philippines, it's actually quite late already, but just to refresh people's memories, so we had this ammonia explosion in an ice plant during the height of the pandemic, which actually complicated the response to this particular incident. And I think one of the highlights of this particular case was the fact that the Poison Center was actually immediately contacted by the first hospital who received the alert and therefore asked for advice. And subsequently, we received calls also not only from the local hospital, but also from some of the first responder community and also the public. But I think, again, in terms of the immediate actions of the Poison Center, we were able to coordinate this immediately with the emergency room, with the consultants, with people who are not on duty, so that we can actually augment our workforce during that particular incident and at the same time be able to cope with the demands of patients coming in for COVID-19. So in terms of what we think is considered to be a highlight for this case, as I mentioned during the February 6th presentation, we actually have a very young patient, an infant who actually was exposed to the ammonia during that particular explosion. And one of the questions I think that emerged during the Slido was whether or not we should decontaminate patients from ammonia, considering that ammonia is a gas. But we actually looked at the aspect of the fact that these patients already came from quite a distance and they already had burning of the skin, burning of the eyes. And that was the reason for why we decided to really decontaminate patients. But I think one of the things we have to remember is that if we have children, and in most of the discussion for chemical incident response, preparedness and response, the aspect of the children having a different kind of process for decontamination is often overlooked. And I think we should really find a module for this kinds of discussion or a way by which we can highlight this, considering that children are not little adults, especially in our case, this was an infant. So it really makes it difficult for people wearing PPE to actually really do decontamination in a young infant, and at the same time ensure that hypothermia will not happen during the process of decontamination. And I think it's a little bit more complicated when you're dealing with children, and so we really need to make sure we train our emergency room staff that just by asking the children to remove their clothing, which is already very important in the aspect of removing the toxicant, as the removal of the clothes by itself can actually take out around 80 to 90% of the contaminant. It might take a longer time for children. They might not, they might refuse to do this procedure and so on. So I think being able to consider these things in the response procedure is also very important. But let me just go back to the issue of the UP National Poison Management and Control Center, because Lesley has adequately presented the issues of the poison center. Our poison center is the oldest poison center in the Philippines, and it has been able to address the issues of so we have a treatment service, we have an analytical service, we have a lot of trainings that we are conducting, and of course we do engage in toxicovigilance. And when it comes to chemicals, highly toxic chemicals, in the aspect of toxicovigilance, we also do a lot of networking with other government agencies, including reporting to relevant agencies when we see that the online sales of these chemicals are actually the ones causing harm. But in this issue of chemical accidents that we have been discussing, again, I picked up something from what Lesley mentioned about national security and having a poison center in a private setting. I think one of the things that perhaps we need to also highlight in the response to chemical incident is that we need to also be able to distinguish at some point whether we are dealing with a deliberate release of a chemical rather than just an accidental release, and how this will actually affect the management of the emergency room physicians. Because I think here in this issue, if this is actually going to be no longer an accident or an unintentional release of a chemical, then there must also be caution taken in as far as making sure that we can gather enough evidence in case people will need to do some kind of prosecution. I am mentioning this because of the current geopolitical conditions that may make it different now when we see patients or incidents or accident, what we think is actually an accident, but in reality is no longer just an accident, but an intentional release. I will leave you with that and turn this over now to Dr. April Llaneta. Thank you.
Thank you, Dr. Irma. Good day, good evening, good morning to everyone. I'd like to share a couple of slides. Dr. Makalinao already gave a summary of the case that we presented in last February 6th. And I would just like to highlight some of the recommendations that I mentioned last time. And I will focus on the communication coordination between Poison Center, the public health authorities, that's under the Department of Health, and the hospital, particularly the emergency department. So there is a need to have a good communication system and coordination among the stakeholders, particularly the Poison Center, hospital, and the public health authorities. So for our particular case in the ammonia incident, we had a hospital operations center that was mainly dealing with the COVID response, but also we were able to use the setup for the ammonia incident. That was a good way. That helps a lot, in communicating between the Poison Center, the hospital, and the public health authorities. For the emergency department, we had a coordination through the Health Emergency Management Bureau for the information that we needed coming from the emergency responders in the field, and then helping us with how we were supposed to deal with the influx of the patients. So information such as was decontamination done at the site and what types of patients were coming in helped in our preparation in the ED. And then I did not explain this very well last time, but we have a surveillance unit at the hospital, and it also played a role during the ammonia incident. So when we have reportable cases, including cases in mass casualty incidents, we coordinate data gathering and reporting cases through the surveillance unit, and we report directly to the Department of Health through its epidemiology bureau. So that was during the ammonia. And also regarding training and simulation exercise, we've had good working relationship with the Poison Center. So we've done simulation exercises and joint training with the Poison Center team. the first responders or the pre-healthcare providers, emergency care, and the hospital and emergency department staff. So that's covers the recommendations. Thank you very much.
Thank you very much, Dr. Makalinao and Dr. Llaneta, for that. You'll have an opportunity just to rest and reflect on some of the questions that are coming through at the moment, but we'll take all the questions once we've heard from the case study 4, which was the methanol incident. So I'd again like to welcome Dr. Winai Wananukul, who is the director of the Ramathiboddle Poison Center in Thailand, and Dr. Paroj Suranatwadnich, Deputy Director General of the Department of Medical Sciences at the Ministry of Health in Thailand, to reflect on their incident, looking at what needs to be built or bridged, any other corrections, and then identifying best practice and gaps as well. Thank you, Dr. Winai and Dr. Paroj. Thank you.
Good day, everyone. It's my pleasure to review our incident, the case study that we have presented last week. So today, I and Dr. Bootsakorn will be answer your question after our presentation. For the methanol incident in Thailand, in August 2024, a methanol poisoning incident occurred in the northeastern part of Bangkok, Thailand, where herbal liquor was adulterated with methanol. Patients began presenting at the hospitals nearly 1 day after consuming the herbal liquor. That is quite late. Both the Ramathiboddle Poison Center and the local general hospital, Noparat Ratchathani Hospital, recognized the incident on the same day that the first group of the patient arrived. So for the response, within 48 hours of the initial group of the patient presenting, the Department of Medical Services under Ministry of Public Health promptly established an Emergency Operations Center, or EOC. The EOC facilitated collaboration among multiple agencies involved the incident, which were Bureau of Epidemiology under Department of Disease Control, Royal Thai Police, Excise Department, Department of Health, Public Health Service Centers, and the district service officers under the Bangkok Metropolitan Administration. Network Hospital under Department of Medical Services and Ramathiboddle Poison Center. The key responsibility of the EOC included data collection and patient tracking, standardized treatment guideline, managing the influx of the patients, identifying and containing the source of the adulteration, preventing public panic, providing public education on methanol poisoning, and developing a self-assessment tool for the public. For the Ramathiboddle Poison Center, we work with the EOC to develop the guidelines for managing methanol poisoning cases, ensure timely laboratory confirmation of diagnosis within 24 hours, and offer consultation to the private hospital outside the public service network. For the outcome of this incident, 44 cases of methanol poisoning were identified and treated in the hospital. 10 patients died, primarily due to multi-organ failure. So the mortality rate was 22.7%. The incident was contained and resolved within 7 days of the first patients presenting. For the incident investigation, the police conducted an investigation into the source of the methanol and revealed that all the herbal liquor originate from the same supplier. This supplier has been consistently purchasing ethanol from a particular vendor for an extended period. However, for this occasion, the vendor provides methanol instead of ethanol. Although the motive behind this deliberate substitution remains unclear, it appears unlikely to be connected with terrorism. For key takeaway, firstly, effective response to chemical incident requires cooperation of multiple agencies, directly improve the specific event. The public health services, especially the Ministry of Public Health, play a central role in leading the response or act as a major stakeholder. Poison Center provides critical expertise in the clinical management of poisoning cases. Secondly, strong collaboration between public health services and the Poison Center enhances the country's ability to effectively manage toxicological incidents. Thirdly, each incident provides valuable lessons that can help improve response capabilities in the future. And for the area improvement, a deep understanding of the function and competency of each agency, particularly the Poison Center, is needed. Public health authorities, such as the Ministry of Public Health and the local public health agencies, should maintain the list of the relevant agencies and their competency. This will allow for more efficient mobilization of the resources during emergency. That is my conclusion. Thank you very much. And Dr. Bootsakorn will be answer the question that we did not answer last week. Dr. Bootsakorn, please.
Yeah. For the last session, there's some question. The one question that I don't answer. The question from the participant is that methanol in counterfeit alcohol can be used conversely on purpose to cause major harm or to burden the public health system. And was there any investigation on that front with the alcohol shops or the employees? And my answer is that, and for the investigation of the shop, after the police receiving the information from the medical team and the emergency operations center, the police investigated all the herbal liquor stalls where the patient reported purchasing and consuming the drinks. And the police traced back to the source of the herbal liquor to is come from a well-known shop in the Bangkok's northeastern district, which is this shop distributed the herbal liquor to the 18 stalls into the area. And following the police inspection, all of these stalls were forced to shut down. And the investigation then revealed that the supplier of the herbal liquor shop had ordered a batch of the ethanol in mid-August, but the owner sold methanol instead. The owner is now under judicial investigation and face charges of attempted murder and adulteration of food, resulting in serious injury and death in the people. And the suspected still deny all charges and claiming that the substitution was done by accidental. But the police suspect that the methanol that was sold in place of the ethanol because of its lower price. Because of in Thailand, the price of the methanol is quite lower than the ethanol for about 2 to 3 times. Yeah. Thank you. Are there any questions?
Yeah, thank you very much, Dr. Bootsakorn, and apologies for not recognizing your attendance today instead of Dr. Paroj. And thank you, Dr. Winai, as well. If we welcome back Dr. Irma and Dr. April as well, we'll open the floor to questions. I will take the questions that are mainly focused on case studies 1 and 4. So I think the first question that we have is from Mark from OECD. As ice plants are common in the Philippines, had information been prepared before the incident so that health and medical staff understood the hazards of ammonia and the response required?
So the UP and PMCC actually produced, together with the Philippine Society of Clinical and Occupational Toxicology, a guidebook called a Guidebook on Chemical Emergencies. So that particular guidebook actually contained ammonia as one of the important agents, because we tried to look at the most common causes of chemical incident releases in the Philippines, and ammonia was actually included. So there is an actual protocol that we have created that includes the pre-hospital, meaning to say it includes what the first responder community can expect to the time the patients are being transported, whether they will go directly to the hospital or they will be transported by the ambulance. And then the poison center, in its we have what we call the common algorithms of poisoning that the UP and PMCC has published. There is also the management for ammonia inside the hospital. But what we actually did during this particular incident is simply to make a simplified version that we actually disseminated in real time to the different hospitals and poison centers that we suspected will be near the incident site.
Right. Thank you, Dr. Irma. Dr. April, anything to add? Or
we've done a few tabletop exercises among the hospital personnel and together with the pre-hospital teams, and some of the cases run ammonia. So I think that also prepared us for the incident.
Thank you. The next question, is there an online platform or database in the Philippines for early warning during chemical incidents or outbreaks?
Unfortunately, there's no online platform. Maybe that's something that we can actually work with the Department of Health. But what we are trying to do now is to map where our chemicals of security concern is actually located. So we are in the process of doing this hazard mapping of these chemicals, and of course trying to find out where the hospitals or assets are in terms of responding just in case it is released, so that we will be able to modify the consequence of the release.
Great. Thank you, Dr. Irma. I think we'll move on to another question, and this is for Dr. Bootsakorn or Dr. Winai. Regarding the methanol poisoning, how did you communicate the risk to the public? Did you have many concerned patients who were not exposed?
During that time, during the methanol incident on August 2024, we communicate with the public via multiple channels, like the online platform, like we use a Facebook, we use the television to publish our information to alert the awareness of the public to stop drinking of the herbal liquor or like the unlicensed ethanol. Yeah. And I think that I concern a lot about the number of patients who suffer from this event. But I think for the Thai patient, at the time, it's quite a well-known news around the country. And I am quite sure that people around that area might know about this news about the methanol outbreak at that time. Yeah.
Thank you, Dr. Bootsakorn. I think there's a second question that's linked, which was, do you think the number of cases, 44, is underreported? And do you think there is a fear from exposed individuals that the information will be shared with the police and the local authorities?
When the team in the Emergency Operations Center talk about the total number of the cases, we concerned that maybe 44 cases maybe is underreported, because around the area of the northeastern part of the Bangkok has a large number of the minors, like foreigners who run the job as workers, but we didn't receive any reported case from the minors. So maybe it's perhaps the number of the 44 is underreported. Yeah.
Thank you. Dr.
Yes,
Winai.
I agree with that. Because in Thailand, we have a universal coverage. So for the Thai people, when they get sick, especially significantly illness, I think that any Thai people will not go to the hospital. So I think for the Thai people, we can include all. But for the foreigners, workers, we might miss some. But because in this incident, we also have a way to communicate with the foreigner with their languages as well, like in the Myanmar languages and Cambodian languages as well. And I think that if we miss, it might be just a minor injury case, not just a significant poisoning from the methanol for this incident. Thank you.
Great. Thank you, Dr. Bootsakorn and Dr. Winai. I think there is a question for Dr. April. What is your opinion on the frequency of multi-partner simulation exercises? Is 1 year sufficient, and how frequently should we be holding these simulations to retain the learning?
Thank you for that question. When we were organized as a CBRN team, we had to do regular exercises, no? So as we included more stakeholders and multiple agencies, so we had to plan the exercises very well. So it takes a lot of logistics, no? And a long time to plan this multi-agency simulation exercises. So I'd say we've done at least twice a year for this type of exercises. And for our in-hospital, we do at least once per quarter.
Great. Thank you, Dr. April. And then there is a question as well for Dr. Irma. I think it says, if you recall correctly, you sometimes communicated with your partners by WhatsApp. Why was this means of communication necessary as opposed to using phones? And did you see any benefits or risks in terms of using other potential platforms as well?
So there are circumstances where we needed to use this either Viber or WhatsApp, simply because these were also being used a lot by our medical doctors. And of course, we still do the actual telephone call. But to be able to transmit the full length of that particular manuscript, we sometimes do use either Viber or WhatsApp. We don't use Telegram, we don't use TikTok when doing these kinds of things. We also use the email, but you have to alert the person that we've sent you an email, please check your email. So those are the things that we have employed. But I understand maybe the rationale for this question is because sometimes the misinformation can actually come in more rapidly using these kinds of tools. But I think we have managed to use this a lot during, especially when we are getting referrals actually outside of Manila.
Thank you. Those are all the questions that we have. There were a few questions that were unanswered from the last session. I think one of those, certainly for Dr. April and Dr. Irma, was, are you able to share the specific decontamination protocol for infants?
Yeah, so actually this is a gray area for us as well. So I couldn't recall, I think April, it was your team. Was it your team who actually decontaminated that young infant? Maybe you can actually say more about this, because the only reason why I mentioned this as an important aspect of that response was because we never really decontaminated any infant in the past. So that is actually for us a very important learning experience. And so when we had this discussion with this was presented in the Philippine Pediatric Society, my hope was really the Philippine Pediatric Society would be more proactive in trying to create a protocol that can be used in case there are subsequent events that require decontamination of infants and children.
Thank you. I think we've come to the end of the time for questions. So again, many thanks to Dr. Irma, Dr. April, Dr. Winai, and Dr. Bootsakorn for taking the time to contribute and to share their knowledge and experience and lessons from their incidents for us to consider how we can address some of the major gaps. So we will now hear from case studies 2, 3, and 5. Reminder to add questions to Slido, and these will be answered once all the case studies have been reviewed. So it gives me great pleasure to invite Dr. Badria Alhatali, head of the Poison Control Section, Ministry of Health in Oman, and Dr. Mohamed Busafi, Director of Emergency Management at the Ministry of Health in Oman, to review their case study on chlorine release. Dr. Mohamed, Dr. Badria, welcome back. I will hand over to you.
Thank you, Robie. Thank you so much. And I would like to thank the organizing committee for having us back again today to give this short summary and highlight some important points. I will just share the summary slide, if you allow me to do that. So the case number 2 was about exposure of chlorine gas in an industrial area. As you know, chlorine gas is an intermediate water-soluble chemical, which is an irritant gas. And so they basically, the expectation of having patients, it depend on the type of the environment where this exposure happened. For our case, it was in an open air in 500 meters away residency area from the place of the incident. The amount that been exposed to is unknown. The hosts were healthy workers that they worked in the factory where the accident happened. We got a total about 42 patients. 30 of them presented to a local hospital, which is Sahar Hospital in this scenario. It was in the around 9 p.m. At night, so there was no alarm of any exposure prior to that. It's only the symptoms that started to happen, and since that drove the cases basically to present to the emergency department. Majority of these cases presented by themselves without the help of the EMS system, and the reason is because there was no alert, and there were few had comorbid conditions, and so the severity of the clinical illness that they presented with was variable at that time. 2 of them required ICU admission, and then luckily we were able to do a follow-up 48 hours and then 2 weeks after the incident to look into the residual incident of this. The beauty about the incident that this happened basically in a hospital where the physician who was in charge is actually clinical toxicologist. So who could realize from the first few cases that presented to the emergency department that we are having, and at that time, of course, he didn't know what kind of exposure these victims had, but he was able to identify this is an irritant gas. And of course, luckily, in a timely manner, he was able to notify the poisoning center as well as the Public Health Emergency Operations Center. Now, this is, as I said, it happened around 9 p.m. And unfortunately, as we have a very, I would say, primitive steps in the development of the poisoning center, a relatively new experience. We are running for about 3 years now. So we have not a 24 hours service. Our service actually closed around 9:30. And so we had to operate and manage these cases throughout the night without direct involvement of the poisoning center as the service is closed. One of the major things that, you know, we were lucky also to have is that the pre-existing contact between the three main players who took lead in the management of this scenario. As I said, the local physician who was a clinical toxicologist who's actually working with us in the poisoning center, Dr. Hassan al-Balushi, and then the Dr. Mohamed al-Busafi, the director of the public health emergency operations center, who's with us today, and me as the director of the poisoning center. So knowing each other probably basically eased the communication among us, and then we were able to basically contain and manage this incident in a very effective time. The clinical management was redirected rapidly by the clinical toxicology team to optimize the resources. And probably this was one of the major things. We were able to basically identify who needs to be decontaminated, where to manage this decontamination, what kind of PPE the physicians need to be aware about, and what is the disposition plan for these cases, and whom can be managed in the emergency department at a tertiary kind of level, who can be managed in a primary healthcare facility, and who can be redirected to the private sectors, which basically also with the involvement of the public health EOC, we were able to basically engage them in this scenario, which basically helped us a lot in planning that. And I will leave the floor at this point to Dr. Mohamed al-Busafi, the director of the public health, to elaborate on the incident and what happened at that day, and what are the lessons that we learned from at that point.
Again, thank you so much, Dr. Badria, for this introduction, and really highly appreciate this very kind gesture from the Global Health Security Initiative to talk about a success story that we're really proud about, and also to discuss the challenges and future improvement opportunities. Again, it was actually out of a sudden that we received that call from the emergency department from one of our colleagues. So yes, we know each other, as Dr. Badria have just mentioned. Luckily, because all of us, me, myself, I'm an emergency physician, board certified emergency physician. Dr. Badria is the same, and our colleague also in the concerned hospital is an emergency physician, and also he's also working with us right now in the regional EOC in that particular governorate of Oman. Yes, the Poison Control Center may not be working 24/7, but the very good thing is in the public health emergency management system in Oman that actually the Public Health Emergency Operations Center is the executive arm of a much bigger sector, which actually comprises basically all healthcare providers in one platform. So whenever there is a resource or there is a necessity, and that necessity is actually in the form of having a public health risk or an emergency, we actually have the privilege, I would say, to ask for support from all concerned colleagues, whether actually they are working with us within the Ministry of Health or in the private sector, or maybe also some other Armed Forces Hospital or Ministry of Agriculture, the Civil Defense. So basically that eases our collaboration and our response when there is an emergency. For this particular incident, what actually I can even recall at this moment that we honestly didn't have that much of a challenge, because again, we knew each other, and the moment actually we received that call from Sohar Hospital, by having this increasing number of patients who are presenting almost with the same symptoms, No one knew actually what was going on at that time, but definitely we knew our partners, we knew our colleagues. So we initiated also the contact with all our concerned stakeholders, obviously also including the Poison Control Center, but also the hazmat sector in the National Emergency Management System. So the National Emergency Management System in Oman is actually not only the health, but actually it's more towards One Health approach by WHO. So we have also a dedicated sector which for hazmat. So they are actually from the civil defense, police, ambulance services, or EMS, and also some other private entities, and also from the armed forces. And we initiate that contact with them, whether if they have received any alert or any notification from Sohar for a probable hazmat incident, but there was none. And as Dr. Badria have just also mentioned, because people had the same symptoms, but they didn't know the cause. However, actually, our colleagues from the civil defense, they showed their very willingness to deploy their hazmat team has there been a need, and they were also at the process of deploying the regional hazmat team and also the national team if there was any need for that. Again, having this large number of patients presenting to a single emergency department almost in the middle of the night, that would have been also a concern, because we already, at that time, we already have that emergency department having almost a surge of patients in that particular time. So definitely we needed to redirect patients to private hospitals. Sometimes probably in other places that might be a concern, but again, the platform that we work on and the MOUs that we already had and the mutual aid agreement that we have already signed with almost all healthcare providers, institutions in Oman, enable us actually to use these resources if there are actually any public health concern or emergency, and that's what happened exactly. So that definitely eased the situation in Sohar emergency department and made also the physician more concerned about the sicker patients, because the ones who were having actually less acute symptoms, or they were actually much more comfortable than others, they were redirected to the private hospitals, knowing that these private hospitals may not have also the appropriate resources as the ones in the government hospital. This is actually, although it was a single incident, and we're really lucky with the agent itself being chlorine, but actually also it brings our attention to the challenges that we can have in the future. I may start with the strength, because the main strength of the public health emergency management in Oman is that for the majority of hospitals, they're government hospitals. So I would say that more than 70% of them. And all of these hospitals, they have actually the very same electronic healthcare system, or electronic patient record that at any moment I can access patient data or patient file in another hospital. So that definitely eases the risk communication, and also makes it much easier for us actually to share patient details, and even definitely for us in the Public Health Emergency Operation Center to establish an incident management system that's also built on information that is a real-time information. The challenge, I would say, in this particular point is that the private hospital don't share the same electronic health system with us at this moment. But actually also there is a huge opportunity of integrating the emergency management or the incident management system during emergencies. So that is also very doable, and we have just started actually that communication with the private hospitals just 2 months ago. And we also had Dr. Hassan Blushi presenting this particular incident to this private hospital in that workshop, in that meeting. I definitely believe that what also made things even much easier for us is the the ongoing training and the ongoing drills and collaboration and that is being done by the Poison Control Center and the National Emergency Management here in Oman. We had a national drill just 2 months ago, and that had a CBRNE scenario, which actually our colleagues in the concerned hospital did really well, and we're really proud about their performance. That also puts another challenge on us because in Oman right now we are having also an influx of industrial zones, and the majority of these industrial zones, they are actually remotely stationed. And what I mean by that is that there are no major hospitals or even secondary hospital close to these industrial sites. So that is another challenge for us in the Public Emergency Operations Center or with our colleagues in the Poison Control Center. But we definitely believe that the ongoing risk communication, the ongoing training, and the ongoing collaboration between private and public, and also when it comes to the public, by the way, we have a very strong collaboration with the armed forces and with the police and with the civil defense. So sharing resources during this time makes our life easy, if I would say that. Again, that's what I can say for the moment, and we're really very happy to receive any questions.
Thank you very much, Dr. Mohamed and Dr. Badria. Really useful reflection on your experience. You'll have a chance to take a break and reflect on some of the questions that are coming in on the Slido, and we'll take all the questions together once colleagues have had a chance to represent their case studies as well. So it gives me great pleasure to introduce colleagues from Canada to discuss the aconite outbreak. So this will be presented by Dr. JinHee Kim, Public Health Physician at Public Health Ontario, Dr. David McVea, Public Health Physician at British Columbia, and Dr. Emily Austin, Medical Director of Ontario Poison Centre, and also Richard Wootton from the chemical team at Health Canada. Thank you all. I look forward to your re-presentation.
Perfect. Well, good day, everyone. Thank you for having us back. We have no conflicts of interest to declare. And just a very quick recap on February 6th, my colleagues and I presented on 2 aconitine outbreak events that occurred in Canada. So we identified a strong need for enhanced linkages and timely information sharing between food safety and toxicovigilance partners, particularly with toxins and heavy metals. Prior to these aconitine events in British Columbia and Ontario, our program in Toxicovigilance Canada in general did not have well-established linkages to food safety programs other than going through our Emergency Operations Centre. Following the events, we set up meetings with the Public Health Agency of Canada's Outbreak Management Division and the Canadian Food Inspection Agency to further discuss the role of poison centres and toxicology laboratories and the support that could be provided in timely detection, analysis, and providing expertise to assist Canada's foodborne illness outbreak response. This resulted in updates to both food safety and toxicovigilance contact lists, notification procedures, including joining together for joint assessments when required. Toxicological events and mass poisoning events, including bioterrorism risks, is an evolving threat for all of us, and we must understand the increasing complexity of toxicological risk management. The world is evolving rapidly, and with the ongoing globalization, we have complex supply chains, increasing the risk of food and product contamination, distribution of counterfeit and non-authorized goods, increasing the risk to complex outbreak events. The aconite example presented touches on many of these complexities, including the need for having a public health surveillance system for early detection of events, especially if these cases are popping up in different areas of the province, country, or even globally. To be successful and best protect and maintain the health of our citizens, we must foster a network of networks, understanding the roles and responsibilities to address toxic risks are shared across many disciplines and jurisdictions. Any large-scale event will require integration between healthcare, public health, regulatory agencies, first responders, law enforcement agencies, and to act in a timely manner. Our team only had one unanswered question from the February 6th presentation. It came from Sharika with the Caribbean Poison Information Network. And for those that do not know her. She was one of the collaborators who helped in drafting the World Health Organization guidelines for establishing a poison center, just a fantastic collaborator. And her question was, the framework presented is very doable. How can we strengthen the communication sharing framework amongst poison centers participating in this symposium? And I'll do my best to answer, and I'm sure Lesley and others can chime in at the end. But I think she's part of the solution. I think the Caribbean Poison Information Network, along with Metatox, EAPCCT, America's Poison Center, Asia Pacific Association of Medical Toxicology, AfriTox, ACMT, CAPCCT, the World Health Organization, and many more of our global toxicovigilance professional bodies and respective public health, regulatory, health security, NGO, academia, clinical care, mental health, and broader communities are part of the solution. Poison centers are keystones of our toxicovigilance networks, given their expertise in real-world evidence on poisonings. From my perspective, we need to foster a global network of networks with regional toxicovigilance focal points to enhance partnerships and collaboration, timely information exchange, common situational awareness, early warning, and reach-back support. I'd like to share a Canadian example of how we benefited from the international support and collaboration of a network of networks. A few years ago, I was on call for the federal health portfolio for chemical emergencies, and I received a phone call from one of our poison centers trying to support local responders with identifying a remediation specialist to support response to a palytoxin exposure event. An entire family had been hospitalized, and the poison center was supporting their medical management. But they needed the support of a remediation specialist. Local responders, not knowing what to do, had literally cordoned off the entire street. I called Canutech, Transport Canada's Dangerous Goods Operations Center, and requested guidance with identifying a remediation specialist from the approved contractors list, but none, unfortunately, could be found. We discussed this. We discovered that this expertise did not exist in Canada after having consulted Canutech, the National Microbiology Laboratory, Toxicovigilance Canada members, Public Health Agency of Canada. And surprise, surprise, in Canada, we don't specialize in toxic coral. We did get 90 centimeters of snow in the last 2 weeks, but toxic coral is not one of our areas of specialty. Our team reached out to the World Health Organization INTOX Network and the Global Health Security Initiative to request guidance from the international community, which came in very quickly from Australia, Hawaii, US CDC, and Public Health Scotland, who'd managed a similar event the year before. This guidance was synthesized and provided to local responders who did the required remediation of the home. Once this was complete, Health Canada's regulatory program, Consumer and Hazardous Product Safety Directorate, requested that we provide them with the local provincial contacts involved in the case to enable the program to have a discussion about possible implications to regulations on the importation of coral, with the goal of identifying opportunities to prevent future similar events. At the domestic and international level, it is clear that we must work across disciplines and jurisdictions to enable timely detection and management of toxic exposures. As stated in the WHO guidelines, health ministries and public health agencies should support toxicovigilance and poison prevention activities in the form of advocacy, facilitation, endorsement, and funding. At the international level, it is necessary to foster toxicovigilance partnerships, enable early warning and reach back, collaborate on poison prevention. I won't go into international health reporting regulations, but this is an important component to be highlighted. I've just pulled this slide from my Metatox presentation that will be given next week. Please let me know if the reference to the Field of Dreams movie is too cheesy. In Canada, we still have a lot more work to do, but if you build it, they will come is exactly how our grassroots collaboration across disciplines and jurisdictions collaboratively built our Canadian Surveillance System for Poison Information program and the broader Toxicovigilance Canada network. We started small by offering other disciplines and jurisdictions access to Poison Center and other toxicovigilance expertise and data. And once they had a taste, we let them know there was so much more that could be done if only we had the resources. From my perspective, far too often, poison centers are only seen for their primary role as clinical care advice service. Their expertise and data which can be critical to guiding prevention, mitigation, preparedness, response, and recovery actions that can be taken by public health, regulatory, health security, mental health, and others, is not always properly recognized. With that, I'd just like to say a huge thank you for the opportunity to participate in the symposium. And in summary, Canada is extremely supportive of fostering development of domestic and international toxicovigilance networks and systems to enhance partnership and collaboration, common situational awareness, early warning, and reach back. We look forward to further discussions on this topic with WHO, the Global Poison Center Network, and our global partners. Thank you.
Right. Thank you, Richard. I'm assuming that you've covered it for everyone. So thank you to Richard, JinHee, Emily, David as well. We will move on to colleagues from the UK to cover case study 5, DNP exposures. So really pleased to welcome Raquel Duarte-Davidson, Head of the Chemicals and Environmental Effects Department and Commissioner for UK National Poisons Information Service, and also Dr. Ruben Thanacoody, who's the Director of the Newcastle Unit of the UK National Poisons Information Service, to reflect on the DNP exposures case study.
So I think just to summarize what the case study was all about, it was about poison centers recognizing the re-emergence of an old threat from 2,4-dinitrophenol, also known as DNP. It's an explosive chemical that was last used as an explosive during the First World War, and then re-emerged in the 1930s when it was discovered that it had weight loss properties. It was used in the United States for treating patients with weight loss, and then was banned under the US Food and Cosmetics Act in 1938. There was a lull in the use of DNP subsequently, but it then re-emerged in the early 2000s as a weight loss drug and fat burning agent that was being purchased via the internet and targeted primarily at bodybuilders, body sculptors who wanted to achieve very low body fat. There were a number of websites marketing DNP for that purpose. The Food Standards Agency in the UK was the regulator and was regulating DNP under the Food Safety Act as not being fit for human consumption as a food supplement. And it issued a health warning in 2003 following the death of a Finnish body sculptor following the use of DNP. In the UK, I think what works quite well for us is that although we have 4 poison centres in 4 geographical locations, 1 in Scotland, 1 in Wales, and 2 in England, we work as an integrated network with all of the enquiries being logged on a single database. And we also provide information directly to healthcare professionals via an online database, which they can log on free of use, free at the point of use, DocSpace. So it is possible for us to undertake toxicovigilance and look at DocSpace accesses from hospitals and other users to see what people are accessing, and also mine the database and look at what people are giving us enquiries about. So in 2012 and 2013, we noted that we were receiving a number of enquiries about DNP, which was very unusual. You can see from that chart there that the number of calls about DNP was 0 to 1 per year. And suddenly there was this increase. Now that sort of increase from 1 to 20 would probably go unrecognized if we didn't have the system that we have currently in place, which is the difficult calls get referred to consultants. And we have a national consultant rota that covers the whole of the UK. And between us, we tend to share these unusual enquiries. So it will come. It's something that we recognize when we are getting more calls about complex or unusual chemicals. It will come to the fore. And hence, this is how it was detected. There were a number of enquiries about DNP in 2012 and 2013. And when we looked at the data in more depth, there it was, a big spike in 2012 and 2013 with 5 deaths recorded, 4 from acute overdose and 1 from a subacute overdose. And subsequently, we we got in touch with Public Health England that commissions the service, or commissioned the service at the time, and it's now UKHSA, and also the Food Standards Agency. And they issued a number of public health messages, which Raquel will talk to you about and explain how that was very successful in regulating DNP in the UK.
Thank you, Ruben. So the next slide tries to highlight the events as they happened, and this is just a summary slide that I presented last Thursday as well. But what it shows is that from 2012-13 or 2011 to 2013, we got a number of peaks and troughs. So basically, we had increase in reported cases being discussed with the NPS, as well as an increase in talkspace accesses, as highlighted here. And what we did is we just, with time, looked at what was happening in terms of reported cases. And we took a number of actions, working together, the NPS, UKHSA, Public Health England then, and FSA as the lead organisation, as Ruben has mentioned. So often when we took action, it did follow with a decrease of information, of cases being reported, and gradually with time, those have dropped to levels which are significantly reduced. And I think we are at the minute in a situation where very few cases are reported. We gave quite a bit of detail at the presentation last week, but I thought that this table or slide summarizes it quite nicely. We've now got implementation of regulation where the MP is in the Poisons Act. And what we need to do now is to continue to see whether levels of cases remain low, because the key source of DNP is the legal purchase of DNP through the dark web. So it's quite important that we continue to be vigilant in terms of what happens next. So now I just wanted to go through some of our successes, which really we did go through it last week, but it's just a recap on what we thought was good. And I think definitely what Ruben has highlighted, we didn't need to have many cases for the NPIS to spot that something was going on, something unusual, and straight away, because of the links and the collaborations we have, we straight away got on the case as soon as the NPIS highlighted this issue. And since then, not only have they continued to monitor what's happening, but we took actions then through the regulator FSA and UKHSA, leading on the advice to public health. And I think that strong collaboration was very successful. It allowed us to understand clearly what was happening, but also to try to provide timely advice to stakeholders as well as affected parties, such as families and relatives. The ongoing toxicovigilance, I think, is a really important way of identifying important public health issues. And Poison Centres are able to do that, as highlighted in this case. And I think that the DNP also highlighted the importance of cross-agency collaboration. So as soon as the issue was raised, we engaged with all the relevant parties, and that allowed us to analyse what was a complex situation, to try to provide the best advice to inform public health and to try to aim to reduce exposures. Clinical management advice was also reviewed in line of the information that was made available, because obviously when there was increased cases of poisoning with DNP, then it was important to see how those cases evolved and see whether the clinical management needed to be changed or updated. And those, so the information provided in our database, Talkspace, was reviewed to that effect. A key challenge, I think, was dealing with families and relatives of affected patients. The patients affected were generally very young, very vulnerable, and obviously it had a huge impact on the families and relatives. So dealing with that was difficult, but again, we worked together to ensure that we aimed to provide the best advice we could based on what was happening. We found out the change, well, we knew before, but obviously it was key to try to aim to change the legislation, but that was highlighted as a challenge because it's such a complex and lengthy process that, of course, requires us to provide strong evidence and data to highlight the need for the change in legislation. And this was done by the NPIS, UKHSA, FSA, over a number of years until eventually the legislation was changed. We use a database to collate information on poisonings and exposures. And that database is used for us to look at trends, to facilitate searching, detecting and alerting for signals and other toxic products. And the key thing that we would like to do, and we are starting to take forward, is to automate that process. So to have an automated toxicovigilance system that works in a more timely manner. And that is something that was highlighted from this case and from other cases, as it'll be a much more efficient way of gathering information. The next challenge that I wanted to mention, was the importance of proactive follow-up of severe and unusual poisoning cases by poison centre specialists, and that's something that Ruben and the NPIS have continued to take forward at an early stage, as that is a very good way of helping to improve patient outcome. Legislation makes it more difficult to market or to provide a DNP. So now there are measures in place that will make it a bit more difficult, but we need to be mindful that it can still be sold illegally, and therefore having international collaborations is key, as it's not just a UK issue, it's an issue that's happened in other parts of the world as well, as Ruben highlighted last week. And therefore it's very important that we work internationally and collaborate internationally to target sales from unlicensed sources via the dark web. And I think that is the end of the key areas that were highlighted during our presentation. So I'll stop sharing now.
Many thanks, Raquel and Ruben. So if we can invite back colleagues for case studies 2, 3, and 5, and we will start to take questions, of which we have quite a few in the chat already. So first one is for Canadian presenters. Are you planning any exercises involving multi-agency partners, food inspectors, public health poison centres focused on tainted food stocks?
Okay, so one of the things that we're currently working on is building a CSPI signals team protocol for the management of signals detected by poison centers, and how that links with other toxicovigilance partners. And following some of that planning work, there would be sort of an exercise program to develop to be testing how well the planning worked, how effective was the training, and provide some guidance on some of those next steps. But I will let provincial colleagues speak, because of course it's not just a federal government, it's a federal provincial collaboration, and I know there's quite a bit going on at the provincial level, so I'll let David and JinHee add in.
Thanks, Richard. So, we're involved in that initiative that Richard was talking about in British Columbia, and certainly we will be participating in the development of the detection protocol, and then in whatever exercises follow up on that. As to what's happened so far, we have had exercises about large foodborne outbreaks, but we actually haven't had exercises around foodborne outbreaks that involve a chemical contamination. So they tend to be your more typical biological contamination. So it's an area that is, as we saw in the example here, it certainly happens that it's not as well exercised or prepared for. So it's something that we do need to be aware of, and probably will be discussing in the context of the larger toxicovigilance framework and the signals detection.
Just to add that in Ontario, which is where I reside, also the poison center here, the Ontario Poison Center, is involved with the CSPI collaboration that Richard mentioned. In terms of foodborne or toxic events involving food, so non sort of pathogenic outbreaks, I think we haven't had. I'm not aware of any exercises that are planned. I do think that with the addition of Ontario Poison Centre to that protocol that I mentioned a couple of weeks ago, that brings all the parties together, all the partners together related to foodborne illness outbreak investigations. It really does then facilitate entry of these types of situations into that protocol, which is exercised regularly. I mean, at any given time, there could be any number of collaborations that involve foodborne illness outbreaks, mostly related to pathogen-based outbreaks. But now there would be much smoother and more, any other sort of foodborne illness outbreak would readily enter into that protocol. So I think we are, in some ways, even without explicit, exercising of those regarding these types of exposures, I think there is a mechanism ready. I do think there's always room for improvement. And also, I think related to these other non-pathogenic chemical or other types of exposures, there's always potentially other partners that need to be pulled in depending on the situation. So I think that's where I think some of the improvements can occur.
For us, at least in British Columbia, the opposite direction is very common also. So we receive many calls that somebody calls in about worried about a toxic exposure. Often it's shellfish related. In British Columbia, we have a large shoreline, lots of shellfish related calls. And if it looks to be a biological or a pathogen related illness, then we will forward that on to the appropriate food safety team, food safety specialist, local regional health authority to go in and do an investigation, look at it. So we participate sort of in both directions.
Thank you, colleagues. If we move on, this is a question from Mark to Mohamed and Badria. What is Oman going to do to prepare for chemical emergencies with regard to the new industrial zones? This is a great opportunity.
Thank you so much, actually. So indeed, actually, it's a great opportunity in the sense that in Oman, there is a national risk team, which is actually having representatives from all concerned sectors. So when it comes to industrial risks, we as Emergency Operations Center, we are also represented in these section and in these meetings. The beauty of this is that with these multi-million and in fact sometimes even multi-billion dollars of investment, there is actually an obligation from the government to address all public health risk, and we have already started initial discussions and collaboration with these industrial zones on the senses of having preparations for their own first responders on the ground, and also collaborating with the civil defense stations stationed in these industrial zones, and also being involved with us in the early warning network. Because again, at the end of the day, we strongly believe that the initiative has to come also from them by informing us about any concern that they have. That's the easiest way of actually having the buy-in from them. Otherwise, I don't think there's a government that can really force every single company to announce or to be really public about it. It's mistakes or whatever they can call them. So this collaboration and having this trust between the government and also the private sector and these industrial zones will definitely be resulted in more collaboration. They are also asked by the government to have a designated funds for the the early management or for the first responders, so they can definitely dedicate funds for the civil defense as well. Because again, all of these multi-billion dollars of investment in these industrial zones, the current government investment or civil defenses, they may not be enough. So these companies also, they are asked to collaborate with the government, and we already had some very good success stories into industrial zones, and we strongly believe that there is further opportunities for even further more collaboration.
Okay, fantastic, thank you for that. Another question for our Canadian colleagues. To move from response-focused poison center work to toxicovigilance, did data scientists have to be hired? And what was the process for that? Was it the poison centers or the hospital partners or the federal health department?
Yeah, I can start that one. So going back to 2012, we started working with our provincial territorial counterparts in the poison centers. And there was a horizontal business case that was developed in collaboration with all of the partners. And essentially what that really identified was the need for timely data, quality data, and a strong community of practice that can use that, that can be provided that evidence to inform action. As part of that work, when we were developing the options, what came forward was for the federal health portfolio to embed epidemiologists within all 5 of the Canadian poison centers to support surveillance, data quality, regional surveillance, national surveillance. So half of my team actually is embedded within the poison centers. Their role is to support the poison center. Their role is to support provinces and territories where they are, sort of the jurisdiction of that poison center, and of course work at the pan-Canadian level. But that's not the only resources going in that space. I know, there's definitely resources allocated by both BC and Ontario towards this work. So I'll let David and JinHee chime in as well.
Sure, thanks, Richard. So first of all, I'll say the Health Canada program is fantastic. And, like Richard said, we have an epidemiologist from Health Canada embedded within our poison center. She works closely with our team and brings some excellent expertise and those networks and connections into the federal system. And because her colleagues are placed at each poison center across the country, great connections and networking across the country. And then I will also add as a benefit, I mentioned during our main presentation a few weeks ago, in British Columbia, the poison center is embedded within public health. It's embedded within the environmental health team. A strong benefit of that is that all the resources of the public health, the provincial public health agency, are there to support and work on the poison center surveillance and data. So all the epidemiologists, the analysts, the knowledge translation specialists that support a large provincial public health agency are there to support the Drug and Poison Information Center also. So it's a huge benefit to vigilance and surveillance for the Poison Center.
Yeah, so I think Dr. Austin had to sign off, but I believe there is a Health Canada-based Health Canada epidemiologist also at the OPC, Ontario Poison Center. And we are, as I mentioned during the main presentation, working here in Ontario because we are not integrated here with the Ontario Poison Center and public health to build those links.
I'm just going to chime in one other piece. It's on the knowledge translation, and it's not just the provincial, territorial, federal governments and the poison centers. We also have a fairly large contingent of NGOs that support this work with knowledge translation and outreach. So I just want to give a shout out to Parachute, the Canadian Injury Prevention Centers, and partners like the Canadian Pediatric Society and others that are part of the public outreach and communications working group, where we try to harmonize messaging. They do a tremendous amount of good as well for mis and disinformation, where people don't necessarily trust governments. This is another voice, another trusted voice that's able to bring good information. So it's not just about the epidemiologists can't stand alone. They need the specialists in poison information, the medical toxicologists, but you also need those specialists in knowledge translation that can get the message to the people in whatever form it needs to be delivered.
Fantastic, thank you. I'm going to use my prerogative to take the next two questions together as they're fairly similar. So the first one is specifically to colleagues from Oman, is how early during the response operation was the poison center informed? The assumption is the main focus would initially be on the response, the evacuation and the decontamination, but did the poison center or public health send a communication to the public on possible chlorine exposure and symptoms? And the next question, which will open up to the floor for others to comment on, is do you find that healthcare providers, emergency responders, tend to call the poison center immediately if there's a chemical suspected or a chemical incident suspected, or do you feel that there's a delay, and what do we need to do to remind emergency responders, public health entities, hospitals to keep their poison center in their minds to assist in a response? So initially, if Mohamed or Badria want to address the question for Oman, and then open up to others about the broader question.
Yeah. So I guess in this scenario, again, we were lucky to have a toxicologist on board when it happened. So there was no, I would say, almost there was no gap in terms of the time, from the time that he realized that there was a gas exposure until he called the poison center. And they actually, the reason why he's calling, it was to notify the center, as well as brainstorming regarding what is the possible toxidrome that we are dealing with, looking into the signs and symptoms that these workers presented with. And so we were basically discussing what kind of, do we really need decontamination at this point? What kind of decontamination that can be used? Can we do that inside the hospital, or we need to have external decontamination? Do we need to send these cases, do they have enough capacity basically to deal with these cases, or we need to send them somewhere else? So we were brainstorming all of this, and that's the point where the emergency response system were with us. Basically, we called Mohamed and we discussed is the capacity and the possibility of the surgeon involving other sectors in this scenario. Although the number was not huge, 42 cases, but all of them almost presented in an hour time. And at that time, at night in a hospital where it's considered a secondary kind of care. So that was basically overwhelming for the limited resources that they had. And I guess the question about sending communication to the public, I think we were lucky to have this been in a residency for workers. So involving basically the supervisors at that point, we were advising them that you might experience these signs and symptoms. We want you to get to the nearest, healthcare facility to get checked and evaluated. Of course, this has been, followed later on the next day with a public announcement that we had a chlorine exposure, and probably Mohamed can speak about that, but the role of the poisoning center was highlighted at this point. And so that was some sort of, advertisement also for the role of the poisoning centers in such chemical incidents where they need to be notified. Now, when it comes to how is the providers, healthcare providers or the emergency response tend to call the poisoning center immediately, we see discrepancy. So if this is coming from the emergency departments, they know us that we are there, so they tend to call us first before the doing anything for the patients or along with their initial assessment. Whereas for the emergency responders, because their communication with the EOC is faster usually, so it goes through them, and then from them, they they notify us that, you know, we are dealing with such a chemical. So, but it's either way, we don't see much, you know, delay when it comes to the communication, because as Mohamed said, you know, having this kind of like constant collaboration between us, we, both of us, like, you know, the poisoning center as well as the emergency operations center, we are under the umbrella of the Ministry of Health. So it's just much easier, you know, way of communication. And Mohamed, if you want to comment additionally on that.
Yeah, so actually, I mean, very like the part of public information. So, so actually, this particular incident was an opportunity for all of us actually to tell our public that we do have a poison control center, because again, we utilize the opportunity to announce about that in social media and even in public TV stations. So, in fact, actually, I got a question from one of the common TV presenters here. So he actually asked that very particular question: do we have poison control center in Oman? And he said, yes, we do have poison control center, and we do have 8 local toxicologists. They are all internationally trained. So that was really a very good advertisement for all of us, actually. And following that, we received also multiple inquiries and questions from other colleagues also. From the first responders, whom are actually the civil defense and the EMS. And I think also you can recall that we had some shared workshops and training with the EMS personnel as well. Doing a public announcement sometimes may not be also necessarily having had a qualified consultant who really realized that this is very, very most probably a chlorine, it's an irritant gas, and it was an open space. Sometimes actually when you announce about it publicly on spots, you would have the opposite of what you were aiming for. So emergency department where we work also will be flooded by patients and others. So, but we do have that public notification platform. So if there was an incident that our colleague as toxicologists or other stakeholders realized or believed that this is a public health concern. So we do have a platform on which actually we can strategically actually take that decision and have mass SMS notification. And now there is a public information also through software through the local cellular companies here, local mobile companies. So they can actually mass notify people in that particular area also.
Great, thank you very much. I'll open the floor for others if they wish to comment on the sort of notification arrangements between the emergency responders and all the hospitals with poison centers.
I'm happy to maybe start commenting on this.
Yep.
So the arrangements we have in the UK, I think, are quite good to have that link between the poison centres and the response function, because we have as Ruben has said, we've got we've got a number of units, but those units collect the information nationally, but also we have a commissioning service, which means that there's close links between those that lead on the chemical incident response and the poison service. So I commission the service and work very closely with the NPS, and then UKHSA does provide the response service when the 24/7 response when there is a chemical incident. So we really work together to ensure that we have a smooth response. I'm sure that we could improve things, but I think that those links are quite good and well established and do work quite well and speed up the response when required.
Thank you, Raquel.
If I could add on to what Raquel has just said, is what we also have in the UK is DocSpace. So whenever there's a chemical incident at the front door of an emergency department, their first response would be to look it up on DocSpace. And so if we then highlight on DocSpace that this is a hazardous chemical and they need to ring the poison center, then they will get in touch with the poison center as the first port of call. And we have a protocol in place between the poison center that we will take those chemicals call and then pass it on, field it to UKHSA's chemical response team. So I think that works quite well, this arrangement, in terms of people at the front door having access to specialist teams and specialist advice.
Thank you, Ruben. Okay, we'll move on. It's a fairly similar one, asking how often poison centers are currently involved in chemical outbreaks or incidents notifications in Canada, and how can the toxicovigilance framework improve on this? That's one specifically for Canada. Any takers?
I can start if Tim wants. So I think, safety signals are identified by poison centers or requests for enhanced monitoring because of things that we know are going on internationally that we want to be aware of. It's fairly common that, things of public health, regulatory health security are coming forward. With respect to the second part of the question, how can the framework improve on this? So much of what we've done has been informal. We've built, a really strong network, and we've built strong relationships. And, that Toxicovigilance Canada network up until this point has really just been that, 450 disciplines members crossing disciplines and jurisdictions working together. But what hasn't happened is, in all cases, is the inclusion of the poison centers, the tox labs, the other toxicovigilance partners into the formal plans. And I think that's the next big step for us, is making sure that we've properly integrated the poison centers, the tox labs, the tox partners into the plans. And by doing that, documenting the roles and responsibilities and the expectations, I think it'll also assist with some of the resource challenges that we've talked about through the symposium, where poison centers aren't necessarily recognized for the value across the broad spectrum that they can bring. Having people included in plans means that they're part of the exercise process. They're part of the planning process when we have major mass gathering events and things like that. So I think, the framework and the formalization of how we all work together is a critical next step. And I'll stop there and open it to Dave and JinHee.
Thanks. I can just add, I'm not, again, part of the Poison Center, and I mentioned that we are building those connections within Ontario. And, we already have, great informal relationship, and, we are always exchanging questions, information, in that informal capacity. And I agree with Richard that that some formalization would be really helpful as well. I think, though, just anecdotally hearing from various poison center, more than one at least, poison center experiences in Canada, I think one of the things that their primary commitment is to support clinicians who are dealing with ongoing clinical scenarios or questions from the public about something that's coming up for them. And so I think really just building up these networks, connections, really demonstrating the importance of the information that they're collecting for the greater kind of the public health purposes, I think is one of the things that that toxicovigilance framework and just having that network really encourages and facilitates. Because I think, yes, that is of utmost importance and the most urgent thing that they have to focus on. But I think the public health value of poison center data and poison center expertise is somewhat maybe not secondary, but at least it's of a less urgent nature. And so it takes time and energy to build those things. And I think having the network really helps to promote that.
I'm just going to jump right back in for 1 second. When we started building C-SPY, I'll never forget the then president of the CAPCCT said to me, he says, "We're so busy pulling drowning people from the river, we have no time to look upstream to see who's pushing them in." And that's something I think we have to do together, because it crosses disciplines and jurisdictions as to who can actually help. So just wanted to add that little tidbit on the end.
Fantastic, thank you. I'll take one more question combined. I think it's from Lesley. Raquel, can you identify what it took to get toxicovigilance recognised by UK government as a public health issue? And then just broaden that out a bit more into how can we, as chemical incidents experts, promote the need for poison centre integration into the overall public health response?
Yeah, thank you. Thank you for that question, Lesley. So I think we've always recognised toxicovigilance as being an important issue for public health. And I think maybe Ruben wants to add a bit more in a minute, but we have been, the NPIS does look at issues of concern and has done for many years. So DNP was one that was very clear, because there weren't that many cases, but there was a significant increase in cases. So it just brought it, specifically as an issue for DNP. But we do, the NPS does monitor and looks at trends, for example, carbon monoxide, pesticides, and a number of other chemicals over time. So I think what I highlighted here was that clear link that you can really quite quickly identify an issue just because you see that increase in trends. I think what I wanted to mention when I gave the summary is the move from collating the information retrospectively and more manually to the automated approach. And that's what we're looking at taking forward at the minute, just to be more efficient. So because we need to every so often update our database where we collect information on exposures and poisonings, then it would make sense to make that more automated. I don't know whether you wanted to add anything to that, Ruben.
No, I think, as you said, Raquel, I think the poison centres in the UK have always been involved in toxicovigilance, but it's largely based on people identifying a signal just simply because there's been a cluster of cases, something like that. There isn't an automated way of identifying a microsignal, and I think that's one of the challenges. But otherwise, we've always been involved in toxicovigilance, and we highlight in our annual report every year issues of concern around chemicals. And there's been several over the years: sodium nitrite, carbon monoxide, pesticides, recreational drugs. So the list goes on. So it's something we've done as a matter of routine in UK poison centres. But it would be good to have an automated manner of doing this. And also, I'm really quite interested by the Canadian model of having epidemiologists embedded within the poison centres.
Yeah, that's good. And the second part of the question, I think that it is key. You're right, it's important to try to see how we can promote chemical incident response, make it more institutionalized. I think from our side, we do, because we have that close link, as I mentioned earlier, between public health and the the public health chemical response, as well as the clinical management response to chemicals. But I do think this often the focus on other areas that poison centres look at may overshadow chemical incidents because they don't happen that often in many countries, or because those poison centres may have less specialism in chemicals. So I do think it's very important to promote the importance of chemical experts. And I don't know whether anybody else may want to add to that.
Yeah, I was just going to say that within British Columbia, at our poison centre, we work quite hard to raise the profile of the poison centre and take advantage of the poison centre through other aspects of public health work. So just to give two examples, like many places across the world, in British Columbia, we're struggling with a toxic drug overdose crisis of contaminated drug supply, many overdose deaths. So the poison centre frequently responds to acute poisoning related to those, but the public health system is working on guidance around safe inhalation and on recovery and from overdose and so on and so forth. the expertise of the medical toxicologists and the poisons specialists has been very important. So the public health system can access those people, get their guidance, get their information and their input on how to respond to an acute overdose event, how to respond to say inhalation drugs exposure that had happened in a hospital room, for example, and how long does it need to be ventilated for? Do surfaces need to be cleaned and so on? So having that expertise from the medical toxicologist informs the rest of the public health service, which is fantastic. And another example in which we access that expertise is in injury prevention. So we have a separate public health injury prevention team, but the poison specialists and the medical toxicologists collaborate and participate from the poison center in that and give their expertise on self-harm and on other overdoses and on things like button batteries, for example, or other kind of non-toxic things you may not think about that get a lot of calls into the poison center. So it's a strategy to raise the profile of the poison center and really show its importance, its benefit, but it also benefits the rest of the public health system that have access to the expertise from the medical toxicologists.
Yeah, I just wanted to respond quickly to Ruben's comment about the automated, sort of data-driven surveillance. And I think obviously that's a value add, particularly when you can combine the EPIs with the medical toxicologist, poison center specialists. But something I always say to my team is, here's a challenge. Can you beat the event-based surveillance where the clinician that's taking the call, engages and see something, say something? So as much as I think we should be investing in automated surveillance, I think we also need to foster that specialist in the loop, see something, say something, because that's hard to beat. And I think the advantage of that as well is it's accessible to, sort of all income countries. This concept of just setting up a mechanism for timely reporting of, I had a case like this, and it is of concern. So, Robbie, I'll stop. Time, please go ahead.
Right, fantastic, Richard. Yeah, we're running slightly over time, but I think it was really important discussion to have. So again, many thanks to Badria, Mohamed, JinHee, David, Emily, Richard, Raquel, and Ruben for taking the time to contribute and share your vast experience, knowledge, and lessons, which has really enhanced this symposium today. So finally, without further ado, we have the final three case studies to review. Please do continue to add your questions to Slido. So we have case study 6, which is the Matheson Molypack fire. Unfortunately, Dr. Juan Carlos Bustamante and Guido Martinez Reyes aren't able to join us, but we do have Daniel Eduardo Fuentes and Patricio Andres Medel Jara, who presented previously. So over to you to introduce your Matheson Molypack fire review. Thank you.
Thank you, Robie. Hello, everyone. For our poison center, located in Chile, it's a real pleasure to participate in this symposium, to share experience and expand our network with other poison centers worldwide. With Patricio, we are stepping in for Dr. Juan Carlos Rios, who is currently on vacation. We both work in the Poison Center in Chile, CITUC. Well, our Poison Center provides a free service offering toxicology guidance to the general public and healthcare professionals. It's operate 24/7, 365 days a year, and covering the entire country. Our Poison Center is structured into 3 specialized operational centers. The first one, the Poison Center, which provides immediately assistance and expert guidance for poisoning cases. The second, our Chemical Emergency Center, who established as a part of Poison Center following WHO recommendation to efficiently manage a chemical emergency while minimizing the high cost typically associated with the standalone Chemical Emergency Center. And the last one, our Pharmacovigilance Center, who is in charge of monitors, receive, and report adverse drug reaction and vaccine-related events. In addition, these three centers, our poison centers, operate three specialized service provision units. The first one are the risk assessment unit, which I'm in charge of, focus on evaluating risk associated with chemical substance. The second are the Chemical Regulatory Affairs Management Unit, who is in charge of manage chemical substance through regulatory and compliance and policies. And the last one are continuing education and training units, which provide specialized training and professional development to enhance expertise in the field of toxicology and risk assessment. Also, we have in the Poison Center a call registration system, an electronic platform that record all the call received our Poison Center. We receive almost 35,000 calls a year. So this data collected for any research and publication on the epidemiology and poisoning in our country, Chile. Additionally, our Poison Center is currently developing a Latin American and Caribbean Poison Center network to share information and strengthen poisoning prevention efforts across the region. Well, now I will provide a brief overview of our case study on the 1995 chemical fire at the Mathisen Molypack Company facility, focusing on our strategic response and the key lesson learned from the incident. The incident involved a massive fire at the warehouse storing chemical substance, requiring effective coordination among multiple health and safety agencies. Our particular intervention underscored the critical importance of preparedness and cooperation between Poison Center and the public health entities. About the key takeaway from the case study, first, prompt recognition of our limitation. We quickly identify our limitation in direct experience with the chemical fire, which led us to seek external assistance. The second was management of the insufficient information. The lack of detailed record about the storage substance complicated the initial management of the incident, obviously. And the last will be significant institutional support. The collaboration with Chemtrec was crucial in providing an informed and effective response. About the necessary improvement for a Poison Center, specifically what need to build, we established specialized chemical emergency centers equipped with a comprehensive database of a chemical substance to enhance preparedness and response. About what need to be bridged, improved communication lines between Poison Centers and emergency response agency to facilitate more coordinated and efficient interventions. And about what level course adjustment or correction would need to be made, will course adjustment implement periodic training programs for emergency personnel to ensure they are up to date with the latest protocol and best practices. Finally, our conclusion and recommendation from the Molypack fire, we learned the importance of continually improving our information system and training to effectively manage the chemical emergency. We recommended the establishment of more specialized chemical emergency centers and the continued enhancement of the response capacity for the Poison Center. Thank you very much.
Many thanks, Daniel and Patricio. You've made now rest a while as the questions are input into the Slido, and I will then invite our colleagues to present case study 7 from Bootsakorn poisoning. So I'd like to invite Dr. Justin Arnold, Medical Director of the Florida Poison Information Center, Dr. Prakash Malay, a chemical surveillance epidemiologist at the Florida Department of Health, to present on their case.
Well, thank you again for the opportunity to share our experiences with this incredible group. I've really learned a lot of take-home points from all the discussions, so thank you ahead of time. I'd like to briefly just recap the incident of brodifacoum contaminated synthetic cannabinoids that occurred in Florida, December of 2021. So on Friday, December 3rd, 2021, we noticed 2 patients with a history of synthetic cannabinoid use who presented to 2 different hospitals for evaluation for abnormal bleeding. The following morning, we received several other phone calls from multiple other hospitals with that reminded us of a similar event that occurred in Chicago 2018. We reached out to the Florida Department of Health to report our observation and began an investigation. And we'd worked closely with the Department of Health in several other public health events in the past. So picking up the phone and kind of quickly coming to an agreement on how we would coordinate this response was really easy to do, and really an invaluable component of I think, the success in this event. Clinically, patients presented with unexplained bleeding, including hematuria, hematemesis, bleeding from the gingiva and vagina, as well as melena and easy bruising. Most all these patients had INRs that were immeasurably high. We worked with the DEA, Tox, and NMS laboratories to identify synthetic cannabinoids and the anticoagulants that were present in the drug product itself. Initially, this was qualitative assessments, but really within several days, we were able to quantify the brodifacoum concentrations. Patients were managed by emergent correction using high doses of vitamin K, as well as fresh frozen plasma and 4-factor prothrombin complex concentrates. And the patients did require really high doses of vitamin K for several months until their brodifacoum concentrations were less than 10 nanograms per ml. We did require really high doses, up to 150 milligrams of vitamin K per day in several cases. And again, this went on for several months. The success of this really depended on our collaboration with several partners. We reached out pretty early in the event to a national medical director listserv that's maintained by all the poison centers to discuss our findings. And really within hours, we received several emails back, one particularly from the Illinois Poison Center that shared their experiences and a lot of their resources from the 2018 event. We coordinated with the Department of Health as well as local law enforcement to disseminate the information using faxes sent to emergency departments, outreach, and we also tried to find ways to connect with the patients directly. The Department of Health was also able to provide letters to clinicians, press releases, and other outreach materials. We disseminated the information eventually in a CDC MMWR report. And probably one of that we really had was obtaining adequate vitamin K to continue to treat the patients, as really the vitamin K supply was limited, it was expensive, and a lot of our patients were homeless or uninsured and really couldn't access care without a donation from Amnio Pharmaceuticals. We ended up using a single pharmacy at a hospital to distribute the medications that were donated, and then we relied pretty heavily on county healthcare plans and federally qualified healthcare centers to provide the outpatient follow-up care. In the end, we had a total of 52 patients that were affected in this event, and unfortunately, there were 4 fatalities. Our longest patient required treatment for about 8 months, and I will hand this off to Dr. Malay to talk about the key takeaway points from this collaboration.
Thank you, Dr. Arnold. So I just want to talk a little bit about the substance. The synthetic cannabinoids are classified as Schedule I substance, which means a drug with no current acceptable medical use and high potency or potential for abuse. So despite of this, many synthetic cannabinoids remain widely available in the United States. They are often marketed as marijuana alternatives or labeled as not for human consumption. So these substances are like inexpensive, undetectable in routine drug tests, and mostly unregulated, and leads to variable compositions and unpredictable health effects. So when we had this incident, while responding to our brodifacoum poisoning after use of the synthetic cannabinoids, as Dr. Arnold mentioned, the collaboration was key because we have different expertise and it's compatible, and working together is the key point. And I just want to echo what other presenters have also mentioned on that. So collaboration with other agencies was crucial in our timely public health response. So we had a coordinated efforts between multiple stakeholders, and it helped us identify a patient population that was affected and also ensuring the treatment availability. So I want to highlight like 3 major challenges we had. The first one was about medication availability and access, and Dr. Anal briefly mentioned that. So we worked with our local pharmacies and then also with the hospitals to make sure that there is availability, and then at the end we work with the pharmaceutical company to donate it. So there's a little bit success story on that. And the second challenge we had was about lab testing. So detecting brodifacum poisoning requires specialized anticoagulant panel testing, which was very costly. And considering the population affected, having that timely testing done from a private laboratory was one of the challenges we had initially. Ultimately, we were collaborated with the DEA lab and got that testing done for no cost for all the patients. And the third challenge we had was patient compliance and adherence to treatment due to high cost and cumbersome nature of the treatment regime. It made it very difficult for patients to adhere to the treatment. So at the end, like we secured the drug at no cost, and also we worked with our federally qualified healthcare clinics to provide that primary care and follow-up care for all the patients. So I just want to highlight that despite lessons learned from similar outbreak in 2018, barriers such as the vitamin K availability still persisted. Moving forward, strategies to mitigate future incidents includes improving access to care, securing sustainable medication assistance, and enhancing laboratory testing capabilities for brodifacum poisoning is important. Also, to prevent future outbreaks, we informed law enforcement about the location where patients had purchased brodifacum list synthetic cannabinoid products. So, and along with that, strong public health messaging is also crucial to raise awareness about the dangers of using these kind of substance abuse drugs like synthetic cannabinoids, and particularly among high-risk population like the one we had, like homeless population. They are low income, low education, which makes them even more vulnerable to have any of these kind of poisonings or get susceptible to have poisonings like this. So additionally, engaging substance abuse services and community coalitions can also enhance outreach and prevention efforts. So I think the collaboration is a key here, and we highly value all the agencies and the partnerships that worked with us on this one. Just to sidestep from our main topic, I want to take a minute to talk about our national efforts to improve public health and poison control center collaboration. The Poison Center and the Public Health Collaboration Community of Practice was established by the Center for Disease Control in 2010 to enhance cooperation between federal, state, and local public health agencies and poison centers. And this collaboration enables better data sharing and toxicology service and emergency response. And it also helps us to develop best practices for managing poisonings and outbreaks. So there are national efforts to enhance the collaboration between public health and poison control. So I just wanted to highlight that, which helped a lot of states to share their best practices with other states and get them up to the speed. At the end, like thank you all for your time and opportunity to present this symposium. So I really appreciate it.
Great, thank you very much, Justin and Prakash. Again, a brief period to rest and address any, we'll think through any questions that are coming up in the Slido. Again, for participants, please do continue to add those to the Slido. And it's time to finally invite our final case study, the paralytic shellfish poisoning presented by colleagues in Oregon. Dr. Robert Hendrickson, emergency physician and medical toxicologist at the Oregon Health and Science University in Portland, and Taryn Grill-Braith, applied epidemiology fellow at the Council of State and Territorial Epidemiologists in Oregon. Welcome both very much. Thank you.
Great, thank you, Robbie. Yes, our case series was cases of paralytic shellfish poisoning. They occurred in Oregon, which is in the northwest corner of the United States with a fairly long coastline. And paralytic shellfish poisoning is, just to kind of remind you and bring everyone back up to speed, is a clinical syndrome that is caused usually by ingesting toxins, usually in bivalves like mussels and clams. The toxin itself is produced by dinoflagellates and filtered by mussels, clams, and other bivalves. And then patients get symptoms when they ingest those. In Oregon, we have a pretty comprehensive system of testing for one of the main toxins in paralytic shellfish poisoning, which is saxitoxin, as well as domoic acid and other toxins on a fairly regular basis. And it's important to recognize that when this event happened, the testing had been done previously and had been normal. And so these beaches were open for foraging mussels and clams at the time. And our event happened on a long holiday weekend that classically starts the summer, and so lots of people going to the coast. Our initial call was during a 3-day holiday weekend. It was about 10 p.m. And the Poison Center got a report from an emergency department, which was well inland, about 70 miles inland from the coast, and reported a case that clinically sounded like paralytic shellfish poisoning. Contacted the local public health agency where they foraged the mussels. By the morning, we got additional cases that sounded like paralytic shellfish poisoning, and at that point activated the state public health system. We immediately had discussions with the duty officer on call, determined our initial plan of action, which was the Poison Center would begin to send information to healthcare providers by sending faxes to emergency departments, asking, with information about paralytic shellfish poisoning, and asking them to contact the Poison Center and have the Poison Center act as this sort of early data collection instrument, if you will, before the public health system stood up their more formal data collection process. We also alerted the media to try to get in touch with people who may have foraged already some of those bivalves. And that was a rather successful endeavor as well, with multiple television and radio interviews we did that morning, as well as a pretty significant social media campaign, not only through the Poison Center, but also by amplifying the public health agencies' messaging as well. And so we sort of amplified each other's messages, and I think got the word out pretty well. I would say, I'm going to hand it off in just a minute, but I would say that we had overall was a pretty successful handling of this outbreak. But it does underline, I think, the importance to fund, support, and expand the role of poison centers as truly a comprehensive public health entity. Poison Center, in this case, represented the only healthcare provider that was really available 24/7. Poison centers are able to detect unusual outbreaks like this one. And we talked a lot about toxicovigilance already today. The Poison Center can function as an early source of trusted information to healthcare providers as well as to the public, and can also function as that early reporting agency and early data collection instrument to assist the public health agency until they can stand up their system. And if in the future, having done a lot of thinking about this, I realized that if our Department of Fish and Wildlife does a great job of testing on a regular basis, And in hindsight, it would have been really smart. And I think in looking ahead, we will do this, is to have a process in place to respond immediately to elevated concentrations of saxitoxin that they detect in shellfish, and to do exactly what we did, but maybe a little bit quicker next time, and maybe a little bit more polished and prepared in the end. With that, I will hand it off to Taryn to talk to you about the public health response.
Thanks. And I would also like to echo that coordinated communication among all of our partners and agencies that were involved in this response was absolutely key. So in total, there were 42 cases of paralytic shellfish poisoning reported over 15 days. Recreationally harvested mussels with very high levels of saxitoxin were the implicated vehicles. For strengths of kind of coordination and communication between Oregon Poison Center and Oregon Health Authority, the first of which was how quickly the reports came in. And this really facilitated, one, the rapid reporting of cases and their suspected illnesses, but also that kind of rapid report really allowed Oregon Health Authority to quickly notify on our end, the public to the risk of disease related to shellfish exposures. And additionally, to work with Oregon Department of Fish and Wildlife to close those beaches to recreational harvesting. We were also able to really quickly notify our provider networks and our partners at both the county and state levels of, hey, this illness is here, be aware, be on the lookout for cases. And that was multi-agency across several jurisdictions. And so overall, the relative speed was a great strength of this response. For our multi-agency response, we did deploy a focus questionnaire to gather data on clinical symptoms, shellfish exposures, harvest locations, and as well care-seeking behaviors. And so the questionnaire was deployed within the week of the initial report. It was deployed via SurveyMonkey for two different reasons, the first of which was active case finding, potentially trying to find cases that would not have been reported to the Poison Center or via traditional disease surveillance methods. And then also as a data entry tool for interviews that were being done by state and local epidemiologists of known cases that had already been reported. And we were successful with that tool. We did identify 10 cases that were not reported to the Poison Center or identified via healthcare facilities, traditional disease reporting routes. One area that we've kind of discussed internally at OHA briefly, I think, is getting the data from the Poison Center reports into our state case investigation system is manual in nature, and fellows like myself and our EIS officers were transferring those data in real time. And so one area of interest following the response was essentially how can we maybe integrate these data systems? How can we make them talk to each other to streamline data reporting into our statewide case investigation system? And so at the time, at this time, we don't know what that would look like, but there's certainly interest in discussing this with our informatics team at OHA and kind of thinking about, how do we potentially build these partnerships for future responses? And then similarly, following our response, like with a lot of the things we do in public health, we did discuss a lot, what worked well and what didn't well. And the survey tool was great for rapid development, but it certainly needed some adjustments after the response. And so we did lead a review of that survey and the data tool and have since made those updates. And so it is ready to be deployed for a future response to an outbreak of this nature. And then the last thing we wanted to discuss as kind of an area of improvement was the relative signage that went up at these various beaches along the coast for to warn of toxic shellfish and basically say, don't harvest shellfish here. If you recall, I did post a picture of a field trip, I'll say, we took to the coast after the outbreak, and some of those signs were pretty difficult to pick out on the beach bulletin boards. And so overall, making that signage more visible, getting the word out a little bit more at the actual sites that, hey, there are toxic shellfish here, please don't harvest. But with that, I will stop there. Thank you for the opportunity to speak.
Thank you, Rob and Taryn. I think we will invite back all the presenters for this last case study session, and we will then open for questions. So we've got a few already in the chat. So I think if we start off one for Florida colleagues, would having public lab services for people to test their illicit drugs without risk of presumably criminal charges for contaminants help to mitigate future contamination events?
The short answer is I don't think so. I mean, the reason is if somebody comes with the product and asks us to test it for specific chemicals, it's gonna be like overwhelming for us to do so without a good reason to do it. From the public health perspective, if there is a contaminant like brodifacoum, which is, we need to have it. We need to have address from a public health perspective, not like individual go one-on-one, because like these drug abuse, illicit drug abuse, and it's hard for us to imagine that somebody who's using synthetic cannabinoid have a good time and then come and say like, can you test it for brodifacoum because I heard about it, which is unlikely to have that kind of. But certainly we do receive for other chemicals, we do receive such complaints like testing well water for pesticides because they live close to the agriculture community and there is spraying going on. And those kind of concerns can be addressed from our water program and the testing well waters program. So we have such programs and those can be go one-on-one basis. And I see value in doing those kind of testing based on the individual requests. But in our case, I don't think there is a value as such.
Justin, do you want to add?
Yeah, yeah, and I'll just add. I agree with Prakash on this. I do envy some of the programs that exist in Europe, like the EMDCCA program that does some product testing and publishes on that too. I've found that product testing is really difficult in the United States. There's not a lot of laboratories that do very specialized laboratory testing on drug product itself. I think a lot of times we lean into the Drug Enforcement Agency, which ends up kind of bringing in the law enforcement component, which would significantly discourage people from submitting samples. But from a harm reduction perspective, I would love to see that be something that we could do. I think there's also, admittedly, a lot of mistrust in the United States right now with government and law enforcement and officials. So that kind of places another barrier up there, but maybe someday.
No, it's a complex issue, especially for public bodies. Prakash, I think you wanted to come in.
Yeah, just one more point I want to make. The reason people choose synthetic cannabinoid versus the legal medical marijuana is because it doesn't get detected in the lab test, regular lab test, drug test. And I don't think like somebody's gonna again try to test it. Like there is a specialized test we need to order to get this detected. It doesn't cover in our regular drug testing. So
thank you. Next question is: does the Poison Center in Oregon get inquiries about other sources of contaminants such as oil, diesel spills, and how good is the connection with the Food Safety Department?
Yes. Two ways that happens. One, it's actually interesting because when this paralytic shellfish poisoning event occurred, I had already spoken to the duty officer earlier that day because there was an oil spill off the coast of Oregon. So we do get contacted by citizens, if they see, and in fact, in this oil spill, one of the initial indications was that someone had noticed a bunch of oil or tar on a beach. And so they called the Poison Center to alert us to that. If that happens, then we would then go through our public health alert to get to, and we're connected with the emergency management system in our state, and we're a member of our Oregon emergency management system. So we would alert them, and that's how we would get in contact with all of the agencies, Coast Guard, food, Fish and Wildlife, all of those types of things. And vice versa, I would say as well, because we're a member of the emergency management statewide group. If they are alerted to something, then they will have an all call and will be included in that. So we would then call in, and if there was something for us to do, then we would take care of our role in that as well.
Thank you. Unless Taryn, were you going to add anything, or you?
I would just say there's a system in place at the State Public Health Department to reach our epidemiologists on call day and night every day of the year. And so there is a system in place for communications directly to go to. And That is how we started collecting case data almost immediately on that Saturday the outbreak was reported. Was our on-call epidemiologist over the weekend essentially had a line list for everybody that returned to work as normal on Monday. So there is a communication chain in place there on the public health side of things.
Thank you. The next question, how important is it to establish communication with private labs or hospitals such as NMS, CFSRE, and other labs? We've seen the importance of such connections in some of the case studies today. And is that part of the WHO guidance for response? Unfortunately, I'm not sure about the acronym for NMS, so I don't know which jurisdiction they rest in. So,
sure, I'll start with this. So I mean, I think for our case, it was incredibly important. I mean, I don't think we would have really honestly been able to respond the same way without having these connections. I mean, the NMS is a private laboratory outside of Philadelphia in Pennsylvania in the United States. And they do a lot of specialized testing, toxicologic testing. There really aren't as many labs as I think many people would think that can really do some of the really specialized testing for evolving drugs of abuse or some of these contaminants that we see. I mean, routine drug testing I think can happen in many situations, but really these specialized labs, there's only a few. And when this event happened, I started calling all my friends at these labs, and they were able to really make things happen very quickly. I mean, labs that had a turnaround time of 7 to 10 days. I said, I'm sending the sample overnight to you right now. And he said, I'll run it first thing in the morning. And I'll call you in the afternoon. And so that connection, I mean, if they went through the normal process, the normal routes, we would be a week to 10 days behind on our response. And then the pivot from the qualitative testing to the quantitative testing really happened through one lab director recommending another person that helped us out, the DA Tox labs. And again, those conversations of who can do the testing, how long it could take them to get those machines up and running, because they weren't routine testings to quantitatively measure these things, was really, really helpful. So it's a small world, and I think these connections are important. These labs also, several of them will place like quarterly reports that anyone can access, and I think those are kind of a helpful way to keep up with them. But yeah, the connections, we would not have been able to do this without their help. So I think it was invaluable.
Thank you, Justin. We've got a question now for our colleagues in Chile, and I'll add in a couple of the unanswered ones because I think they're linked to this. Is how is the Poison Center currently embedded in chemical incident response? So what are the improvements compared to the previous decades when the incident happened? And one of the unanswered questions that's linked to this is that with the additional training and resources, would there been a different response in terms of the advice following the incident, i.e. in terms of whether the fire would have been extinguished or people would have been advised to shelter? So I think overall it's what have been the improvements since the incident at, I've forgotten the name of the plant, the Molepac site.
Okay, thank you for the question. I think the main improvement is the visibility of the center in the network of the first responders. So now our state is all the responders know that when we are and the number that they should call if they need information. So the use that the first responders make depends of the incidents. If there is a small, I don't know, spill with no exposed people, probably they didn't call us. So we don't have any role in that type of situation. But when is people exposed or people go to the emergency department being symptomatic, the clinical team and the firefighters, they need to know what is the prognosis of that patient or what's the management. So this is our main role. So when the emergency is happening, this is the role what we have, but there is no a lot of teams in Chile that have what in the environmental impact of the chemical emergency. So there's in some cases another road that is made by Daniel mainly, that is the risk assessment. So that's the role these days now. What is different because the past on the Mollypack the Mollypack incident is that in that time they call us just in case we could help them, because our main role is always clinical with the poisoning patients. So,
thank you. Anything to add, Daniel? Or?
Yeah, I would say too, the other things different is in that time, we don't know what are in those storage. Right now, the regulation actually there exists to the owner maintain this safety data sheet of each product they have. So you already know what are in those, and already to the storage have their system for accumulate some chemical substances with compatibility, whatever. So there is a rules who make a safety management of all the kind of things are in some storage. So that time they don't have any of those things.
Yeah, no, I think there was one of the questions saying that now that you have the safety data sheets and the information, did you suddenly get an increase in the number of calls to the poison center for these incidents?
Yeah, actually, they increase a lot. Yeah. We have right now 35,000 calls a year. So, well, not only related with the chemical substance, but we have a lot of call inside to the poison center.
Yeah, thank you, Patricia, Daniel. The next question is from Sharika. The discussion about accredited and specialized labs for testing is interesting. From the chemical database in each of your jurisdiction, what percentage of those chemicals can be tested with the current lab capacity? Well, that's a challenging one to answer straight off. Anybody want to pick this up, because the range of chemicals is so vast?
Yeah, I'll comment briefly on this, and then I'll also defer to Rob too, because I'm curious what he thinks. I don't know the answer to that question. It's it is such a broad question. I think when I've been watching this question for a minute. So when I look at this, my initial thoughts are, lab testing is not always the end all be all of our response, right? It can be very important. Like in our situation, quantifying the brodifacoum was really helpful for us to understand who would require a longer duration of treatment. So at some point, it became important for us to understand how much vitamin K we were going to anticipate needing, how we would arrange follow-up, those kinds of things. That's how we tried to use that quantitatively. When we first got these cases, it was kind of recognizing what was happening. It was clinically assessing the patient and treating them without having lab testing. And it was a see something, say something. I know someone mentioned that before, right? So we kind of reached out to a lot of the other poison centers and shared this experience, and collectively between our clinical assessment and kind of that shared inquiry, we came up with a plan on how to do this. So I would just highlight that we focus a lot on lab testing in our case, but that was an important part of it, but it's not certainly the complete response. But it's difficult. I mean, there's these specialized tests that exist. I mean, a lot of what's out there honestly focuses on drugs of abuse and novel psychoactive substances, and that's kind of the interest of a lot of these specialized labs. Beyond that, I don't know that there's an easy way to kind of figure out who's going to have the test for what and how to anticipate was we did not anticipate having brodifacoum contaminated synthetic cannabinoids, when we looked at our population. So in retrospect, sure it happened, but it's hard to kind of just be so forward thinking that you can anticipate all those needs. So,
Rob, did you want to add to that?
Yeah, I think I agree. Most of the testing that's available locally is, pharmaceuticals that require monitoring, lithium and digoxin and things like that.
Yeah.
Brodifacoum, there's absolutely no way any local hospital lab would, at least not in my area, would report that. I would probably call the amount of testing we have available locally fairly limited, frankly. In our case, in the saxitoxin case, it was the state lab because they do this all the time. They're testing muscle samples, and there's other agencies. But from a clinical standpoint, I think we have access to very, very few toxins, and we rely very heavily on the specialized labs like NMS and DEA tox.
Yeah, thanks. I think one of the issues is more, do you have the capability to just do, sort of a blind screen to look for anything that's possibly there? And there are some specialist facilities that will be able to do that, especially in academia and other resources as well. So that would tend to be the question rather than matching the potential exposures to what's available locally.
I just have a quick comment on that question. I want to complicate the question further by saying that there are tests available for environmental samples and biological samples.
Yeah.
So sometimes it helps to get involved some agencies that can do environmental testings, for in our United States, we have Department of Agriculture, Consumer Service, who can do testing on soil samples, water samples, and other stuff like that. So it just helps us to put the exposure and the illness together, to break that link. And there was exposure if we know for sure that what chemicals were involved.
Thank you, Prakash, Justin, and Rob. The next one, shellfish poisoning. How many cases need to be reported to picked up to generate the multi-agency response? Would one case initiate such a response?
Go ahead, Rob.
Oh, go ahead. No, go ahead. You.
Okay. I was just thinking, when we start seeing cases that are clustered in time and space like this with common exposures across them, I think our technical definition is 2 to 3 cases. But at this point, when those reports started coming in, there's a lot of people reporting paralytic shellfish poisoning like illness. Those reports coming directly from the poison center. We pretty quickly activated a multi-agency response just because the cases were so clustered in time and space and they were all presenting with compatible illness.
Rob, anything to add? Or
no, yeah, and paralytic shellfish poisoning is a reportable disease. So I think the thing that we would report any case, absolutely. I think the thing that accelerated this, particularly on a long holiday weekend, was collection of cases, just as Taryn said, and also that an action needed to be taken. These beaches were open for harvesting, so and we knew that a long weekend like this is kind of classic foraging time. So that, I think, pushed the multi-agency response to go as quickly as it did, because there was a need for it. If those had already been closed, testing had already been done, I think things still would be reportable, but the response would have been different.
Fantastic. Whilst you've still got the floor, I'll jump to the last question and come back to the final one. So the signages on your field trip, were they in English only or also in other languages? Assumed they already have visuals, but having multilingual signage is important for risk communication.
Yeah, I would absolutely agree. And for the most part, those signs were in English. There was some signs up at kind of isolated beaches that were translated to other languages as well. In some cases, there were QR codes on the signs that could be scanned, and then whoever is at the beach, they could access those same materials in other languages. But one of the issues that we ran into while we were testing that was there's not a lot of cell phone service at our more rural beaches in Oregon, and so that was certainly a barrier to accessing linguistically appropriate materials. We did try to supplement that as we were getting information out to the public. I think I showed it in my presentation last week, but that public-facing one-pager, we translated that into several languages, and we sent that out via provider networks and to our local public health jurisdictions, as well as via social media. And so we were really trying to supplement that kind of break in access there based off of language.
Great. Fantastic. Thank you, Taryn. And our final question, we're just slightly over time. What roles are your informatics team comprised of? I'm not sure to whom that is directed. I don't recall anyone flagging informatics in their teams.
I'm not 100% sure of the question, but I will try to kind of integrate informatics into this. So, one thing that, from a poison center perspective, we have a staff that at the hospital that kind of helps coordinate information. But we also, all the poison centers in the US upload data every 8.5 minutes to our national poison database system, which I think is kind of where this question is going. So what's really nice about the NPDS system is it's a real-time monitoring system that uses some specific informatic algorithms to look for potential cases of public health threats. And it does that particularly through three kind of main mechanisms. One is specific substances. For example, if a poison specialist codes sarin gas, that will one case immediately kind of flag as a concern, right? Alternatively, you can have syndromic surveillance. So if there's someone codes a specific combination of symptoms that would identify with a certain toxin of concern, that would potentially raise a concern. And then the third would be a volume issue. If suddenly there are 10 cases in an hour where there's normally 2, that would draw attention and result in an anomaly. Those anomalies then get communicated back to both the health departments of the states as well as the poison centers themselves. And then we can look into them and see, yes, this is a concern for a public health response, or no, this is not. And so that's kind of the big way I think that we integrate our data to kind of really watch what's happening and how we're responding to it. We also, I know in Florida, also share our data through a program called Essence, and the state health department also monitors that data as well. So we have a few different avenues to watch for these threats.
Thank you, Justin. On that note, unless anyone is desperate to come in on that, I will thank you all again. Many thanks to Daniel, Patricio, Justin, Prakash, Robert, and Taran for taking the time to share your expertise and insight. It is very much appreciated by myself and I'm sure all the delegates. On that note, colleagues, we've reached the end of a thoroughly engaging and enjoyable symposium. I'd firstly like to express my gratitude to all the speakers, contributors for sharing their expertise. If our hosting colleagues can add the link to the evaluation survey to the chat, that would be helpful. The intention is to capture the key themes and proposals for strengthened integration and response to chemical incidents in a report from the symposium. From my personal reflection of the broad discussions, we've touched on a broad range of areas, the importance of partnership working, not just between poison centers and public health agencies, that's national, international, but more broadly with all the other multi-agency partners, regulatory bodies, and wider government departments, as well as private industry. Regular training, exercising, and simulations to strengthen preparedness for chemical incident response. It was recognized that we may have some challenges around resources for poison centers to be able to do that, and some of the logistical challenges still need to be addressed. As Mark highlighted from his presentation, learning lessons to prevent further incidents, not just identifying them, but actually taking it forward and learning. Access to specialist antidotes, as noted from the Florida experience. The importance of automated systems, early warning systems in detecting poisonings. The integration of epidemiologists or data analysts into poison centers. Access to online toxicology databases for multi-agency partners. That might be a solution to address those that aren't open for 24 hours. Integrated health infrastructure really does support the multi-agency response. Toxicovigilance, automation of these systems, early identification of issues, as well as the post-incident follow-up and surveillance, the importance of alerting and communication across all health professionals, lots of discussion around public messaging. Who do we involve? Non-governmental organizations, specialist teams to support that, how we've warn and inform, the effectiveness of different channels as well. In the last session, we talked about laboratory testing capabilities, as well as the importance of environmental monitoring. And finally, the role of the private sector, both health, but also industry, in collaborating to improve preparedness. So I think there's a lot of themes that we've captured there that we can build upon and look to strengthen. My thanks to the delegates for your participation and questions. Without those, the seminar wouldn't have been as successful as it has been. And then my thanks to Lydia, Julie, Barb, and colleagues from the Canadian National Coordinating Centre for Environmental Health. Also to Kelsey and Edgar from the Chemical Emergency Management and Toxicovigilance Division of Health Canada. Without your dedication and support, this symposium wouldn't have been possible. And also, I'd like to express my gratitude to the organising team. And you can also take that opportunity through the evaluation survey as well to provide your feedback. Finally, my thanks to the members of the Chemical Events Working Group, GHSI, and especially Health Canada for their support in delivering this symposium. And at that point, I will hand over to Claude for final comments.
Yeah, thank you. So this is the end of the symposium. I want to thank you, Rob, for wonderfully facilitating this session and for contributing to the success of this symposium by encouraging all those meaningful discussions. The recording of the symposium will be available on the website for people who want to share these very interesting case studies with their colleagues. Before closing the symposium, I would like to thank, on behalf of Health Canada, all the speakers who took the time to prepare and present case studies or international guidelines. I also want to thank all the participants who joined from 79 countries for attending this symposium and contributing to it through their questions and comments. A special thank you to GHSI, who endorsed the organization of the symposium, and the Chemical Event Working Group, who has worked very hard over the last year to prepare this event. I want to thank NCCEH also, who supported the organization of this event, its logistics, and also the elaboration of different deliverables that will be generated by this symposium. So you will have additional news from us. Thank you also to Parachute and the InfoPoison website for hosting all the information regarding this symposium. I want to thank my managers at Health Canada, my Assistant Deputy Minister, Mr. Matt Jones, my Director General, Mr. Tim Singer, and my Director, Ms. Michelle Rejaba-Colonel, who trusted me enough to approve my proposition to host this important symposium. Finally, I want to thank my wonderful division team for all the coordination activities that they supported to deliver this symposium on time. Your dedication to making this event a success means a lot to me. Thanks, everyone, and have a great day.